Hello, my dear students. I welcome you all to this rapid revision series. So, as a part of your rapid revision series, the today's revision series will be about the general medicine, which is one of the very important and scoring subject for your FMG exam. So, I will try to revise the entire general medicine in a very crisp manner. And once the revision session is over, I will be also sending you the material, or I'll be attaching the PDF under the description section. So, I'm myself Dr. Rajesh Gubba. So, I'm the general medicine educator, and I have been teaching the FMGE graduates since almost 10 years. So, with my vast experience on the general medicine, I will try to revise those particular topics which are very important for your exam. Okay, right. So, first and foremost, yes, very good afternoon, everyone. First and foremost, yeah, the very important thing to be noticed is about the decision related to the internship on the FMGs, that is foreign medical graduates. So I deeply condemn the decision of the decision makers who has made the internship for 2 years for the foreign medical graduates. So I'm very painful about this particular decision which has been made by the decision makers. So from my side, I urge or I request the decision makers to revise this particular decision of the internship related to the foreign medical graduate student. So having said this, now let me just tell you what are the revision topics which we are about to discuss now. So these are all the topics which I will be revising now. First and foremost, you need to know in the starting of the session what is that we are about to start the discussion with. Yes, a very good afternoon, everyone. Yeah, I will just confine myself only to the important topics itself. And each particular topic, that is cardiology, endocrinology, neurology, pulmonology, connective tissue disorders, nephrology, and gastroenterology. So I will take like 1 hour for each chapter. Each chapter I will take 1 hour. Now, first starting with the cardiology. So, in this revision series, what is very important that you need to know is ये हमको पता रहना है कि which topics to revise, right? Which topics to emphasize more. That is very important. So, in the first topic, that is the cardiology, the one which I am about to revise is the following topics in the cardiology. That is the heart failure, cardiomyopathies, heart sounds, jugular venous pulse, cardiac murmurs, arterial pulse, valvular heart diseases, pericardial disorders, hypertension, and infective endocarditis. So, the first topic for the revision in the general medicine will be related to the cardiology, and within the cardiology, the first topic will be related to the heart failure. So, we will try to revise together. We will try to revise together. Don't worry about the material. Immediately after the session is over, I will attach this PDF in the description section, and you will be having this session even in a recorded format as well. So, having said this brief introduction, let us start about the revision in the cardiology, and that too the first important topic, that is the heart failure. Okay, so now in the recent exams, you might have observed that the clinical based questions and as well as image based questions have been taken a forward step in the questionnaire. So I tried to make out this revision series in a mixed manner, like the single liner questions will be there, clinical based questions will be there, image based question will be there, and as well as some of the very important single liners also will be there in this session. So taking the entire perspective of how the questions will be asked, I have designed this particular revision series. So having said this, let us start with the first question. Okay, so right, the first question is, a 56-year-old man with history of the coronary artery disease and documented ejection fraction of 40% by echocardiography presents for further management. At this visit, the patient denies having shortness of breath, dyspnea on exertion, orthopnea, or lower extremity edema. He has never been admitted to the hospital for congestive heart failure. So, according to American Heart Association, this particular patient is in which stage of the heart failure is the question, right? So this is the first important clinical question of the revision session. So the options are stage A, B, C and D. So I'll just wait for 10 seconds if there is anyone to answer the question very quickly. Okay, so the first answer is by Irfan. So he says stage A, right? Now let us just try to discuss the stages of the heart failure first. In the heart failure, what we need to know is the stages. Now, okay, so we have the mixed answers. Right, great, great. So some of you have answered it correctly. So, like there are totally 4 stages of heart failure. So what are these 4 stages of heart failure? That is stage A, B, C and as well as D. Now, what is stage A? Stage A is that the individual is at risk of heart failure, but there is no structural disease. That is very, very important. Whereas stage B, the individual is at risk of heart failure. The individual is also having structural disease, but there are no clinical features of the heart failure. Stage C is that along with the structural heart disease, the individual will also have the symptoms of the heart failure. Whereas stage D is refractory. It's an advanced stage of the heart failure. So these are the stages of the heart failure. So taking these points into consideration, right? So which particular stage our patient belongs to? So अगर आप देखें तो patient का क्या है? Like there are no clinical manifestations. Denies the shortness of breath. खाली प्रॉब्लम क्या है पेशेंट को? प्रॉब्लम है कि इजेक्शन फ्रैक्शन बहुत कम है. नॉर्मल इजेक्शन फ्रैक्शन कितना है? 55 to 70%. पेशेंट का इजेक्शन फ्रैक्शन कितना है? 40%. एंड दूसरा प्रॉब्लम है कि पेशेंट को कोरोनरी आर्टरी डिजीज है. बोले तो द पेशेंट इज हैविंग सम स्ट्रक्चरल हार्ट डिजीज, मगर सिम्टम्स है क्या? सिम्टम्स कुछ भी नहीं है. So when symptoms are not there, only structural disease is there. So this particular patient belongs to stage B of the heart failure. So this is the first important clinical question. Having said this, you need to know some of the single liners. What is the most common cause of the right heart failure? Right. So is there anyone to answer this question first? Most common cause of the right heart failure. So most common cause of right heart failure is the left heart failure. Very good, Jinesh. So the most common cause of right heart failure is the left heart failure. Then what is the most common cause of the acute cor pulmonale? The most common cause of acute cor pulmonale, what is this? Most common cause of acute cor pulmonale? That is massive pulmonary embolism. That is the most common cause of the acute cor pulmonale. फिर दूसरा क्वेश्चन है कि मोस्ट कॉमन कॉज ऑफ क्रॉनिक कॉर पल्मोनल क्या होगा? व्हाट विल बी द आंसर फॉर दिस? द मोस्ट कॉमन कॉज ऑफ क्रॉनिक कॉर पल्मोनल विल बी chronic obstructive pulmonary disease. So etiology wise, this is one very, very important. And next thing you need to know is how do we classify this heart failure? See, we classify this heart failure based on the ejection fraction. कैसे क्लासिफाई कर सकते हैं हम? We classify that based on the ejection fraction. So that is heart failure with preserved ejection fraction, और दूसरा होगा heart failure with reduced ejection fraction. फिर normal ejection fraction कितना होगा? Normal ejection fraction है कि 55 to 70%. फिर preserved ejection fraction बोले तो क्या है? It is that where there is heart failure but ejection fraction is preserved. That means it is a diastolic heart failure. फिर दूसरा होगा heart failure with reduced ejection fraction. Reduced ejection fraction बोले तो ejection fraction कम होगा. कितना होगा? It will be less than 40%. Right? So this will be your systolic heart failure. Right? This will be your systolic heart failure. And I will tell you some of the important etiologies. फिर heart failure with preserved ejection fraction जो है किस वजह से हो सकता है, राइट? एक होगा hypertrophic cardiomyopathy, right? One etiology is hypertrophic cardiomyopathy and the other etiology is restrictive cardiomyopathy. फिर heart failure with reduced ejection fraction क्या होगा? That will be your dilated cardiomyopathy and even your coronary artery diseases. So these are the heart failure with reduced ejection fraction. दूसरा क्वेश्चन है कि आपको like what is the earliest manifestation of the heart failure? Any one of you? What is the earliest manifestation of the left heart failure? So is there anyone who can answer this question? Earliest manifestation of left heart failure. Right. So earliest manifestation of left heart failure होगा like patient whenever he is sleeping अचानक बीच में like he gets up with dyspnea. तो उसको हम क्या बोल सकते हैं? What do we call that? We call this as paroxysmal nocturnal dyspnea. So the earliest manifestation of left heart failure will be paroxysmal nocturnal dyspnea. Right. एक very important thing in the very good. Some of you are answering it correctly. I appreciate that. And the next important thing in the heart failure you need to know is how do we classify the severity of dyspnea? We classify the severity of dyspnea based on NYHA, that is New York Heart Association. Right, that is New York Heart Association classification. फिर इसमें क्वेश्चंस क्या पूछेगा आपको? NYHA में क्या क्या पैरामीटर्स हम we will just look into. What are the parameters which we look into in NYHA? NYHA बोले तो it is not just only for dyspnea. NYHA बोले तो right, it tells you about the fatigue, it tells you about the palpitations, it also tells you about the dyspnea. So NYHA classification ratta marna is very important, very important, because the same question on NYHA has been asked even in your recent INI-CT exam as well. So class 1 NYHA बोले तो क्या है? No limitation of the physical activity. अगर ऑर्डिनरी फिजिकल एक्टिविटी करने के समय में पेशेंट को कुछ भी प्रॉब्लम नहीं रहेगा, बट whenever the individual does the same activity on exertional activity करने के समय में the individual will have the dyspnea. फिर क्लास 2 क्या होगा? Slight limitation of the physical activity, otherwise the patient is comfortable at rest, but doing ordinary activity the individual will have fatigue, palpitations and dyspnea. फिर क्लास 3 क्या होगा? क्लास 3 होगा less than ordinary activity. Right, class 3 होगा less than ordinary activity. So on doing less than ordinary activity अगर symptoms develop हुआ patients को, then it is called class 3 NYHA. Then class 4 NYHA क्या है? The individual will have symptoms at rest. कुछ भी नहीं कर सकते patient class 4 में. Class 4 even at rest the individual will have dyspnea, the individual will have palpitations, the individual will have fatigue. That is your class 4 NYHA. So in this, after having discussed about the left heart failure, you need to know what is the earliest manifestation of right heart failure. So is there anyone to answer what is the earliest manifestation of right heart failure? Right. So who will be the first person to answer that? Yes. Who will be the first person to answer that? ना ये liver congestion नहीं होगा. So the earliest manifestation of right heart failure is raised JVP. Right, raised JVP. So increase in the jugular venous pulse is the earliest manifestation of right heart failure. दूसरा क्वेश्चन पूछते हैं आपको हार्ट फेलियर में, what is the respiratory pattern in congestive heart failure? This is one very important question. So heart failure में the type of respiratory manifestation or the breathing that you will have is the Cheyne-Stokes breathing. ये क्या है? What is this Cheyne-Stokes breathing? Cheyne-Stokes breathing बोले तो the individual will have a rapid breathing, followed by that there will be apnea. and again there will be rapid breathing, again there will be apnea. That is what is called as the Cheyne-Stokes breathing. It is characteristically seen in congestive heart failure, right? फिर दूसरा क्वेश्चन क्या है? Another very very important question in the congestive heart failure है कि name of the criteria. Name of the criteria for congestive heart failure. The name of the criteria for congestive heart failure is Framingham's criteria. Right? Name of the criteria है कि Framingham's criteria. That can be asked as a question for you. The next important is the investigations. कैसे investigate करना है ये patient को? So one, you can do chest X-ray. Chest X-ray में क्या दिखेगा आपको? So what will be the first manifestation? Okay, this will be the first manifestation where you will have upper lobe vein distension. You see this? This is what is your upper lobe vein distension. Upper lobe vein distension होने के बाद the fluid will enter into the interstitium. उस वजह से हमको क्या दिखेगा? That will be curly B lines. So you get to see the curly B lines. Then उसके बाद interstitium से the fluid will enter into the alveoli. Thereby you get this bat wing appearance. उसके बाद the patient will develop the pleural effusion. So this is about the chest X-ray findings in patients with the heart failure. So which is that which will tell you that there is increased pulmonary venous pressure? That is option C. So you see the sequence. Number one, upper lobe vein distension. उसके बाद curly B lines. उसके बाद bat wing appearance, that is perihilar edema. Then उसके बाद lastly the pleural effusion. So this will be the chest X-ray findings in patients with a congestive heart failure. Then the next important question होगा आपको, cardiac biomarker क्या है congestive heart failure में? Most sensitive cardiac biomarker, right? So is there anyone who can answer this question? Most sensitive cardiac biomarker क्या होगा patient में, heart failure patient में? Very good, very good. So it is your NT-proBNP. Excellent. That is NT-proBNP. That is the cardiac biomarker. फिर उसके बाद होगा what is the treatment, right? So acute left ventricular failure में drug of choice क्या है? What is the drug of choice for acute left ventricular failure? What will be that? तो acute left ventricular failure में acute pulmonary edema है, पूरा lungs पानी से भरा हुआ है. So फिर क्या देना है हम? What we should give? We should give, very good. So the drug of choice will be the furosemide. Right? Drug of choice will be furosemide. ठीक है? फिर what are the other treatment options? पहले, like what is the first thing that you need to do? Connect the patient to the oxygen. Then the drug of choice will be your diuretics. फिर मॉर्फिन देने के वजह से एडवांटेज क्या होगा? मॉर्फिन देने के एडवांटेज जो है, इट विल रिड्यूस द प्रीलोड. एंड वेसोडाइलेटर्स क्या देना? यू शुड गिव नाइट्रोग्लिसरीन. नाइट्रोग्लिसरीन का एडवांटेज क्या है? नाइट्रोग्लिसरीन जो है ये प्रीलोड भी कम करेगा और ये जो है आफ्टर लोड भी कम करेगा. दैट इज द एडवांटेज ऑफ योर नाइट्रोग्लिसरीन. मगर नाइट्रोग्लिसरीन देने के समय में एक चीज माइंड में याद रखना है कि whenever you are giving nitroglycerin, the systolic blood pressure should be more than 90 millimeters of mercury. This is very very important. Then inotropic agents कब देना है? Whenever the individual develops cardiogenic shock, then you should give inotropic agents like norepinephrine, then dobutamine or dobutamine देना है. So this will be the treatment for acute heart failure. फिर chronic heart failure में treatment क्या होगा? Chronic heart failure में जब like whenever you find that the entire fluid is out of the lung, the individual is completely cleared of your pulmonary edema, then in such case the drugs that you need to give is beta blockers, then AC inhibitors or angiotensin receptor blockers, then aldosterone antagonists. So these are the drugs which will improve the mortality in patients with the हार्ट फेलियर. मगर बीटा ब्लॉकर्स देने के समय में ये चीज याद रखना है कि अगर पेशेंट इज इन क्लास 4 डिस्निया, then don't give beta blockers. Okay, and beta blockers देने के समय में you have to start with low dose and then you have to step up the dose. ये चीज ये माइंड में याद रखना बीटा ब्लॉकर्स देने के समय में. Then right, this is very important question. Preferred drug for heart failure with reduced ejection fraction. ये पक्का क्वेश्चन है, right? Please just keep this as a star mark, right? So please keep this as a star mark and revise even before the exam as well. So preferred drug क्या होगा heart failure with reduced ejection fraction में? Any one of you? Right, very good, excellent, superb. That is angiotensin receptor blocker, neprilysin inhibitor. क्या होगा? angiotensin receptor blocker जो है valsartan. फिर neprilysin inhibitor क्या है? neprilysin inhibitor जो है that is sacubitril. ये कॉम्बिनेशन का एडवांटेज क्या है? ये कॉम्बिनेशन का जो एडवांटेज है that will improve the ejection fraction. That is the advantage of this particular army angiotensin receptor blocker neprilysin inhibitor. ठीक है, ये हो गया आपका हार्ट फेल्यूर का क्विक रिवीजन, 10 मिनट में पूरा खत्म. राइट नाउ, so are you all comfortable with the session which is going on? Yes, quickly respond me on the chat box. Is everything fine? चलो ठीक है, वेरी गुड, सुपर. राइट देन ओके, सो हार्ट फेल्यूर होने के बाद द नेक्स्ट टॉपिक इज कार्डियोमायोपैथी. राइट, सो कार्डियोमायोपैथी में एक हो गया आपका डायलेटेड कार्डियोमायोपैथी, रिस्ट्रिक्टिव कार्डियोमायोपैथी, हाइपरट्रोफिक कार्डियोमायोपैथी. तो ये तीन कार्डियोमायोपैथीज 5-5 मिनट में मैं पूरा डिस्कस करता हूं. राइट, द फर्स्ट वन इज द डायलेटेड कार्डियोमायोपैथी. So you see this question. 24-year male patient presented with history of ataxia of gait with Romberg sign positive and dysmetria. He also complains of dyspnea on exertion. Echo findings kya hai? Like ejection fraction is 30% and dilated chambers. What would be the etiology? Cerebellar ataxia, Friedreich's ataxia, subacute combined degeneration of the spinal cord, then selenium deficiency. तो क्या होगा? What will be the answer for this question? Right. So, okay. एक स्टूडेंट ने करेक्ट आंसर किया है इसका, that is the Friedreich's ataxia. So now dilated chambers are there and there is also the features of cerebellar lesion. Right? So you will see that in case of spinocerebellar ataxia, that is nothing but Friedreich's ataxia. This is one of the common cause for your dilated cardiomyopathy. So दूसरा क्वेश्चन है कि मोस्ट कॉमन टॉक्सिन क्या होगा डायलेटेड कार्डियोमायोपैथी कॉज करने के लिए? मोस्ट कॉमन टॉक्सिन क्या है? मोस्ट कॉमन टॉक्सिन जो है, वेरी गुड, दैट इज अल्कोहल. अल्कोहल जो है मोस्ट कॉमन टॉक्सिन. ठीक है, देन उसके बाद लाइक व्हाट आर द inflammatory causes for dilated cardiomyopathy? Inflammatory causes जो है mainly autoimmune diseases. Anyone want to answer what are the inflammatory causes? That includes systemic lupus erythematosus, दूसरा होगा systemic sclerosis, दूसरा होगा dermatomyositis. These are the inflammatory causes for dilated cardiomyopathy. The next is the nutritional causes. So ये रिविजन सेशन है, राइट? आई एम नॉट टीचिंग यू एनी बेसिक्स हियर. रिविजन सेशन में फटाफट 5 मिनट में एक एक टॉपिक होना है. ठीक है, राइट? सो न्यूट्रिशनल कॉजेस क्या है? न्यूट्रिशनल कॉजेस जो है, वन इज योर B1 डेफिशिएंसी एंड एज वेल एज द सेलेनियम डेफिशिएंसी. ठीक है, राइट? एंडोक्राइन कॉजेस क्या है डायलेटेड कार्डियोमायोपैथी कॉज करने के लिए? ये होगा डायबिटीज मेलिटस, दूसरा होगा थायराइड डिसऑर्डर्स. थायराइड डिसऑर्डर्स क्या है? बोथ हाइपोथायरॉयडिज्म एंड हाइपरथायरॉयडिज्म के वजह से डायलेटेड कार्डियोमायोपैथी होने का चांसेस है. देन द नेक्स्ट इंपॉर्टेंट इज द हेमेटोलॉजिकल कॉजेस. हेमेटोलॉजिकल कॉजेस क्या है डायलेटेड कार्डियोमायोपैथी कॉज करने के लिए? राइट, दैट इज दैट हेमेटोलॉजिकल कंडीशन वेयर यू हैव प्रियापिज्म. वेयर डू यू हैव प्रियापिज्म? You have that in case of sickle cell disease. Right, in sickle cell anemia, right, you will have development of dilated cardiomyopathy. ठीक है, राइट? उसके बाद होगा टॉक्सिन्स. टॉक्सिन्स में ऑलरेडी बोला है, that is alcohol. दूसरा टॉक्सिन्स क्या होगा? ड्रग ऑफ अब्यूज। ये क्या है ड्रग ऑफ अब्यूज? कोकेन इंटॉक्सिकेशन विल कॉज डायलेटेड कार्डियोमायोपैथी। उसके अलावा वी हैव आल्सो सम कीमोथेरेप्यूटिक ड्रग्स लाइक अड्रियामाइसिन, ट्रांसट्यूजुमैब, साइक्लोफॉस्फोमाइड। दीज आर द अदर टॉक्सिन्स व्हिच विल कॉज डायलेटेड कार्डियोमायोपैथी। ठीक है। देन उसके बाद हो गया आपका इनफिल्ट्रेटिव कॉजेस। क्या है वो इनफिल्ट्रेटिव कॉजेस? इनफिल्ट्रेटिव कॉजेस जो है हीमोक्रोमैटोसिस। तो हीमोक्रोमैटोसिस जो है it not only causes dilated cardiomyopathy, hemochromatosis will also cause restrictive cardiomyopathy. So please remember the infiltrative causes. Then okay, one question from one of my brother that sir ये जो है ये बस है क्या? Right? Trust me, just follow my session until the end. ये पूरा बस हो जाएगा. From this session, whatever you are going to spend me almost like 7 to 8 hours or 8 to 9 hours, that will give you 25 marks. 25 marks definitely you will get from this session. I will 100% guarantee you. Just follow until end. Okay? Right. Then, okay. So now this will be about your right. So this, the next important is क्लिनिकल फीचर्स क्या होगा इसमें? ये जो हार्ट फेलियर कर रहे तो डिस्निया होगा. एंड हाउ विल यू डायग्नोज दिस डायलेटेड कार्डियोमायोपैथी? पहले है कि कार्डियोमेगाली. राइट. सो चेस्ट एक्सरे में कार्डियोमेगाली का क्राइटेरिया क्या होगा? राइट. यस चिनू माय ब्रदर, इट इज बोथ. इवन नीट पीजी को भी यूज होगा और एफएमजी को भी यूज होगा. राइट. Yes, Jamal, good afternoon. Very good. So, criteria जो है, cardiothoracic ratio should be more than 0.5, right? So, cardiothoracic ratio जो है, that should be more than 0.5. Okay, that will be there in the dilated cardiomyopathy. Next, coming to the treatment. And first line investigation क्या है dilated cardiomyopathy में? First line investigation जो है, that will be 2D echo. Very simple. 2D इको में क्या दिखेगा? 2D इको में डायलेटेड चेंबर्स दिखेगा. 2D इको में इजेक्शन फ्रैक्शन कैलकुलेट कर सकते हैं. फिर इजेक्शन फ्रैक्शन क्या होगा डायलेटेड कार्डियोमायोपैथी में? इजेक्शन फ्रैक्शन कम रहता है. दैट इज हार्ट फेलियर विथ रिड्यूस्ड इजेक्शन फ्रैक्शन. कितना इजेक्शन फ्रैक्शन रहता? इट विल बी लेस देन 40%. राइट. इट विल बी लेस देन 40%. ओके. राइट. Then the next important is the treatment part. Which of the following drug is not given in dilated cardiomyopathy? Right, fatafat. Right, so I want the answers from you. Yes, yes, even functional MR and functional TR is also seen. Very good. Right, fatafat bolna hai. Very good, excellent, superb. Right, so जब भी अगर इजेक्शन फ्रैक्शन कम है पेशेंट में, कैल्शियम चैनल ब्लॉकर नहीं देना. वेरी वेरी इंपॉर्टेंट पॉइंट. यू शुड नॉट गिव कैल्शियम चैनल ब्लॉकर. कैल्शियम चैनल ब्लॉकर देने के, अगर कैल्शियम चैनल ब्लॉकर दे दिया पेशेंट को, क्या होगा? और इजेक्शन फ्रैक्शन और कम करेगा कैल्शियम चैनल ब्लॉकर्स. तो इसलिए कैल्शियम चैनल ब्लॉकर्स डायलेटेड कार्डियोमायोपैथी पेशेंट्स को नहीं देना. ठीक है? Is it clear? Calcium channel blockers don't give in patients with reduced ejection fraction. Right? Okay. The next important is an image-based question. Indication of this device in dilated cardiomyopathy with left bundle branch block patients. First of all, ये device क्या है? क्या identify करना आपने? पहले हमको बोलो, like what is this device? All of you, what is this device? Yes, नरसिम्हा, you can give बीटा ब्लॉकर्स. बीटा ब्लॉकर्स दे सकते हैं, मगर बीटा ब्लॉकर्स कब नहीं देना है? अगर पेशेंट्स क्लास 4 NYHA है, if the patient is in class 4 NYHA, then don't give beta blockers. ठीक है? नहीं बच्चों, नहीं my dear students, it is not pacemaker. It is not pacemaker. अरे भाई साहब जमाल, ये किंडरगार्टन का क्वेश्चन नहीं है, ये पेसमेकर नहीं है. This is not pacemaker. This is not defibrillator. Right? So what is this? This is your CRT, cardiac resynchronization therapy. Right? What is this? This is CRT, cardiac resynchronization therapy. So, sir, कैसे पता करना है? How to identify it is CRT? In CRT, you will have 3 leads. Right? CRT में कितना लीड्स रहेगा? 3 लीड्स रहेगा. एक हो गया राइट एट्रियम में, दूसरा हो गया राइट वेंट्रिकल में, तीसरा हो गया लेटरल वॉल ऑफ द लेफ्ट वेंट्रिकल में तीसरा लीड रहेगा. ठीक है? राइट. नाउ आई विल जस्ट शो यू इन द एक्सरे ऑल्सो. राइट, एक हो गया राइट एट्रियम, दूसरा हो गया राइट वेंट्रिकल, तीसरा हो गया लेटरल वॉल ऑफ द लेफ्ट वेंट्रिकल. ये कार्डियक रीसिंक्रोनाइजेशन थेरेपी जो है, we place that in refractory cases of dilated cardiomyopathy. Dilated cardiomyopathy patients को 6 महीने मेडिकल मैनेजमेंट देना है. You have to give 6 months of medical management. In spite of medical management, if the patient does not respond, then you have to put the patient on CRT, cardiac resynchronization therapy. फिर ये इंडिकेशंस क्या है इसका? ये कार्डियक रीसिंक्रोनाइजेशन थेरेपी करने का मतलब क्या है? दिस विल इंप्रूव द इजेक्शन फ्रैक्शन ऑफ द पेशेंट. तो what is the indication? Indication जो है, patient with dilated cardiomyopathy with wide QRS complex. कितना wide QRS complex है ना? More than 120 milliseconds. Right? More than 120 milliseconds. आप बोल सकते हैं सर लेफ्ट बंडल ब्रांच ब्लॉक में वाइड QRS कॉम्प्लेक्स जरूर रहेगा, बट in case of LBBB patients, the QRS duration should be more than 150 milliseconds. If no LBBB, if LBBB is not there in the ECG, then in such case, the QRS complex should be more than 120 milliseconds. हमने like very preferably आवाज in LBBB. So LBBB, left bundle branch block, QRS complex will be wide. But in DCMP, what is the indication for CRT? It should be more than 150 milliseconds. अगर LBBB नहीं है, then QRS complex should be more than 120 milliseconds. I hope I am very clear with this question. अगर कुछ भी doubt है इस question के ऊपर, then you can ask me. Definitely I will answer you. Right. Right. So what is this? This is CRT, cardiac resynchronization therapy. ठीक है. अगर ये question clear हो गया, then we will move on to the next. Right. Next topic जो है पेरीपार्टम कार्डियोमायोपैथी. पेरीपार्टम कार्डियोमायोपैथी का मतलब क्या है? डेफिनेशन इटसेल्फ इज अ वेरी वेरी इंपॉर्टेंट क्वेश्चन. पेरीपार्टम कार्डियोमायोपैथी जो है, डेवलपमेंट ऑफ डायलेटेड कार्डियोमायोपैथी इन ए प्रेग्नेंट फीमेल. राइट, प्रेग्नेंट फीमेल बोले तो किस महीने में? इज इट लाइक फर्स्ट महीने, सेकेंड महीने, थर्ड महीने? नो 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 नो. Development of dilated cardiomyopathy in the last month of pregnancy, right? In the last month of pregnancy or within 6 months, right? Within 6 months of delivery, then we use the word peripartum cardiomyopathy. और दूसरा क्राइटेरिया, बहुत इंपॉर्टेंट क्राइटेरिया जो है, there should be absence of demonstrable cause for the heart failure. ये क्या है? That is, ये pregnant female में, ये female जो who has developed this dilated cardiomyopathy in last month of pregnancy or within 6 months of delivery, there should be no pre-existing cardiac disease. Right? There should be no pre-existing cardiac disease. That is very very important to call it as peripartum cardiomyopathy. अगर pre-existing cardiac disease है, then it is not peripartum cardiomyopathy. Right? So definition itself is a multiple choice question for you. ठीक है? Right? फिर treatment क्या देना है ये patients को? What is the treatment for this peripartum cardiomyopathy? We should give beta blocker. Which beta blocker is good enough? That is sotalol. Sotalol is acceptable. राइट, तो इट इज वेरी मच इफेक्टिव. उसके अलावा क्या ड्रग्स देना है? बीटा ब्लॉकर्स के अलावा the same treatment whatever we give in dilated cardiomyopathy. एक ही चीज, which drugs you will not give in dilated cardiomyopathy. I have given you the list of drugs just now. One particular drug which you are giving in dilated cardiomyopathy you cannot give in peripartum cardiomyopathy. वो drug क्या है? What is that? What is that? No, calcium channel blockers तो definitely नहीं देना है. No, okay. ना. See, yes, one student has answered it correctly. That is ACE inhibitors. So ये patients को beta blockers दे सकते हैं, diuretics दे सकते हैं, hydralazine दे सकते और nitrates दे सकते, मगर ACE inhibitors नहीं देना. Now you should answer this question. ACE inhibitors काहे को नहीं दे सकते? Why we cannot give ACE inhibitors in a pregnant female? Yes, Kritika. Yes. I'll speak in English as well. Yes, teratogenic, because ACE inhibitors are teratogenic. That will cause renal agenesis. That will cause renal agenesis. That is the reason why you should not give ACE inhibitors in case of peripartum cardiomyopathy. Right, Mukesh ji, I will speak in English and as well as mixed it with Hindi. Okay, very good. Now, then we'll move on to the next important form of cardiomyopathy. दूसरा होगा Takotsubo cardiomyopathy. What is this Takotsubo cardiomyopathy? Any one of you? Yes, what is Takotsubo cardiomyopathy? ना. Irfan, it is not toxic. ये होगा आपका dilated cardiomyopathy. It is a form of dilated cardiomyopathy. दूसरा नाम क्या है? What are the other names for this Takotsubo cardiomyopathy? दूसरा नाम जो है, it is also called stress cardiomyopathy. Why? Because it occurs whenever the individual is under severe stress, where there is massive release of catecholamines. फिर it is also called apical ballooning syndrome. किस वजह से इस पेशेंट्स को apical ballooning syndrome बोलते हैं? Because it is the apex of the heart which is ballooned out. That is why it is called apical ballooning syndrome. Then the other name is broken heart syndrome. See, the apex which is ballooned out, जो भी apex balloon हो गया, there is very high chance that it can rupture. अगर rupture हो गए तो उसको क्या बोलते हैं हम? broken heart syndrome. फिर दूसरा नाम जो है Takotsubo cardiomyopathy. किस वजह से Takotsubo बोलते हैं हम? That is because जापान में एक ऑब्जेक्ट यूज करते. इन जापान वी यूज एन ऑब्जेक्ट टू कैच दिस ऑक्टोपस. वो ऑब्जेक्ट का नाम क्या है? वो ऑब्जेक्ट का नाम है Takotsubo. ये जो भी एपेक्स ballooned out हो गया, it is looking similar to that of Takotsubo. That is the reason why it is called Takotsubo cardiomyopathy. ठीक है? ये Takotsubo cardiomyopathy का क्राइटेरिया क्या है? The criteria is the Mayo's criteria. 4 important criteria जरूर याद रखना. You should remember all these 4 criteria. Number 1, 2D echo will be showing apical hypokinesia. Number 2, absence of coronary artery occlusion by thrombus. When you do a coronary angiogram, the coronary should be absolutely clear. ECG, ST segment elevation. Troponin elevated. Very important. Absence of pheochromocytoma. क्यों? Because pheochromocytoma also there is massive release of catecholamines. In that way, you should rule out pheochromocytoma. Because in Takotsubo क्या होगा? Massive release of catecholamines होगा. Pheochromocytoma में क्या होगा? Massive release of catecholamines. दोनों same है एक क्या? No. Both are not same. Both are different. So there should be absence of the pheochromocytoma. So this is what is your modified Mayo's criteria. 4 out of 4 should be there. Here, like what is the treatment in case of Takotsubo cardiomyopathy? The treatment is we give aspirin. And then the same thing, beta blockers, ACE inhibitors, everything we give. But only thing is, if the patient with Takotsubo cardiomyopathy, if they develop cardiogenic shock, then you have to put the patient on IABP, intra-aortic balloon pump. ठीक है? Right? एक चीज याद रखना, one important thing you should remember, if there is cardiogenic shock, नॉरएपिनेफ्रिन दे सकते हैं? नो. डोपामिन दे सकते हैं क्या? नो. डोब्यूटामिन दे सकते हैं क्या? नो. राइट? सो इफ देयर इज कार्डियोजेनिक शॉक, प्लीज डोंट गिव नॉरएपिनेफ्रिन, डोपामिन, डोबिटामिन. क्यों? बिकॉज ये जो टाकोसुबो कार्डियोमायोपैथी किस वजह से डेवलप हो रहे? मैसिव कैटेकोलामाइन रिलीज की वजह से डेवलप हो रहे. एंड अगेन अपॉन दैट इफ यू गिव दीज ड्रग्स दैट विल फर्दर वर्सन द कंडीशन, right? That will further worsen the condition. Okay, so that is about your dilated cardiomyopathy. The next important form of cardiomyopathy जो है hypertrophic cardiomyopathy, right? So एक question देखो आपने, image based question. All are true regarding the specimen shown except asymmetrical septal hypertrophy, left ventricular outflow tract obstruction, diamond shaped cavity of the left ventricle, diastolic dysfunction. Except, what is the wrong statement here? What is the wrong statement here? Right, very good Narsimha. So, diamond shaped cavity nahi rehta. What is this? This is a specimen of hypertrophic cardiomyopathy. So, in hypertrophic cardiomyopathy, what will be the shape of the LV? Very good Irfan. That will be banana shaped LV. Right, banana shaped cavity rehta, not diamond shaped cavity. Diastolic dysfunction रहता, left ventricular outflow obstruction रहता, and asymmetrical septal hypertrophy also will be there, right? So, what is the definition of your hypertrophic obstructive cardiomyopathy? One important thing, ये जो hypertrophy जो है, whatever this hypertrophy is there, this particular hypertrophy thickness, this thickness should be more than 1.5 centimeter. And this particular thickness, it need not be only in the septum. This particular thickness can be there even at the apex. If it is at the apex, we call it as apical hypertrophy. Right? If it is at the apex, we call it as apical hypertrophy. If it is at the septum, it will, see, agar hypertrophy, if it is there at the septum, what it will do? It will obstruct the outflow. इस वजह से ये पेशेंट्स को हम हाइपरट्रोफिक ऑब्स्ट्रक्टिव कार्डियोमायोपैथी बोल सकते हैं, राइट? सो हाइपरट्रोफिक ऑब्स्ट्रक्टिव कार्डियोमायोपैथी में बनाना शेप्ड लेफ्ट वेंट्रिकुलर ल्यूमेन. फिर ये एपाइकल हाइपरट्रोफी में व्हाट विल बी द शेप ऑफ द एलवी ल्यूमेन? अगर एपाइकल हाइपरट्रोफी है पेशेंट को, देन इट विल बी द एस ऑफ स्पेड्स, राइट? इट विल बी एस ऑफ स्पेड्स. ठीक है, right? What will be the, yes, mutation, right? Jaldi bolo, what mutation is most common in patients with hypertrophic cardiomyopathy? Very, very important question. Yes, very good. That is beta myosin gene mutation. Okay, and one more thing that they may ask you is on which chromosome? It is present on chromosome 14. What type of inheritance? Inheritance जो है autosomal dominant type of inheritance. Then apart from this beta myosin, what are the other proteins which are defective? The other proteins which are defective is troponin T, myosin binding protein C. These are the other proteins which are being defective. ठीक है, right? Presentation क्या होगा? Clinically how do they present? Right? Very बुरा बात है कि most common presentation है sudden cardiac death. They directly present with sudden cardiac death on doing some exertional activity, right? So that is the asymptomatic presentation. Okay, so I don't know how many of you have gone through the news. एक news है कि recently, I think it was yesterday or day before yesterday, Bangalore में there is one individual who had affair with the domestic helper, and he was having intercourse with the domestic help, and with the excessive excitation he had a sudden cardiac death. Autopsy किए तो HOCM निकल गया, right? So on exertion the individual can have sudden cardiac death. ठीक है, अगर symptomatic है patient, then what will be the symptom? The most common symptom जो है, right? Most common symptom जो है dyspnea. And what is the important auscultatory finding? So along with S1 and S2, right? Along with S1 and S2, Any additional sound आपको सुनेगा क्या? Do you listen any other additional heart sound apart from S1 and S2 in HOCM? Yes. What is that? That is your S4. Right? Apart from this, you also listen a murmur. What is that murmur? That will be ejection systolic murmur. Right? That will be the ejection systolic murmur. Okay? Then, next is what will be the first line investigation. First line investigation जो है, that will be 2D echo. Confirmatory diagnosis जो है, the confirmatory diagnosis is by cardiac MRI. Right? That is by cardiac MRI. That will confirm the diagnosis. Right? Then, what will the ECG show? ECG in patients with the hypertrophic cardiomyopathy, right, that will show you features of left ventricular hypertrophy. Right? Features of left ventricular hypertrophy. That will be there on the ECG. लेफ्ट वेंट्रिकुलर हाइपरट्रोफी का क्राइटेरिया क्या है? वो जो क्राइटेरिया है सोकोलो-लियोन क्राइटेरिया, राइट? सो सोकोलो-लियोन क्राइटेरिया, okay? And I have seen many of the students that they will remember this criteria as Sunny-Leone criteria. Remember, it is not Sunny-Leone criteria, it is Sokolov-Leone criteria. Okay, sir, mnemonic, like it is very easy to remember, that is why I just remember. But exam में Sokolov-Leone criteria tick करना है. Sokolov-Leone criteria क्या है? What is that? That is SV1 plus RV5 or RV6. It is more than 35 mm, right? More than 35 mm. That should be your Sokolov-Leone criteria, which is suggestive of your left ventricular hypertrophy. Which is suggestive of your left ventricular hypertrophy. Okay? No. Please don't remember it as Sunny-Leone criteria. It is Sokolov-Leone criteria. Okay? Right. Next, you see the treatment. So you see the clinical scenario. 9-month-old child of a diabetic mother presents with tachypnea and hepatomegaly. Echocardiography showed normal morphology and asymmetrical septal hypertrophy. Which of the following you will give to treat this particular child? Digoxin, furosemide, propranolol, isopten. What will you give? So what is very important here? That is asymmetrical septal hypertrophy. So the drug of choice will be beta blocker. Drug of choice will be beta blocker, and that too which beta blocker we can give? That is propranolol. अगर beta blockers का कुछ भी contraindications है, then the alternative drug will be calcium channel blocker, that is verapamil. Right? That is verapamil. Okay? Right. And next important thing you need to know is there are some drugs which are contraindicated in HOCM. What are those drugs which are contraindicated in HOCM? Digitalis, mat dena. Sympathomimetic amines, no. Nitrates, no. Diuretics, no. Why? Because when you give these drugs, they will decrease the LV lumen and they will increase the obstruction. That is the reason why these drugs are contraindicated. Then, ये हो गया आपका hypertrophic cardiomyopathy. Then, next important is the restrictive cardiomyopathy. Restrictive cardiomyopathy, like what exactly is the definition? ये जो है, this is the one which will cause diastolic dysfunction. ठीक है? And there will be abnormal material which accumulates within the myocardium, and thereby the myocardium becomes stiff. Right? It becomes so stiff that it will resist, the ventricles will resist the normal filling during diastole. The heart cannot relax properly. So, it will be heart failure with preserved ejection fraction. Right? Very good. What is the most common etiology causing restrictive cardiomyopathy? Right? Everyone remembers amyloidosis. मगर उधर क्वेश्चन क्या पूछेगा आपको? Which type of amyloidosis? AA, AL, A beta. Okay, some AA amyloidosis. Okay, AA तो already मैं पूछ लिया. Right. Yeah. Now you tell me. नहीं, A beta नहीं है, AA नहीं है. That will be AL amyloidosis. light chain type of amyloidosis, that is the most common cause for restrictive cardiomyopathy. Everyone remembers amyloidosis. उधर googly क्या होगा? Which subtype of amyloidosis? That will be AL type of amyloidosis. ठीक है? दूसरा, what is the other important etiology causing restrictive cardiomyopathy? एक storage disorder है. What is that storage disorder? That is Fabry's disease. ये Fabry's disease जो है, it is a lysosomal storage disorder. Right? It is lysosomal storage disorder. Okay. Now, what is the question here? Question पूछेगा आपको enzymatic deficiency क्या है Fabry's में? Anyone can answer this question? Fabry's में enzymatic deficiency क्या है? Any one of you? Right. So we have one student. Very good. Very good. Now everyone is answering. That is alpha galactosidase A deficiency. Right? Alpha galactosidase A deficiency. ये deficiency की वजह से क्या होगा? What will happen because of this deficiency? There will be excessive accumulation of a fat. What is that particular fat which will get accumulated? Globotriaosylceramide. Right? Globotriaosylceramide, that will accumulate and that will be responsible for the development of restrictive cardiomyopathy. Okay, please answer this question. What is the antibody in this condition causing restrictive cardiomyopathy? Anti-Smith, anti-centromere, anti-topoisomerase, anti-dsDNA. First of all, please tell me what is the diagnosis? Diagnosis क्या होगा? This will be scleroderma, right? You can see the skin, it is very tight skin, and you can see the mouth. She is unable to open the mouth. Where will you get that? You will get that in scleroderma. Scleroderma is two types. एक होगा localized scleroderma, दूसरा होगा systemic scleroderma. And in which type of scleroderma you will have restrictive cardiomyopathy? In systemic scleroderma. In systemic scleroderma, you will have development of restrictive cardiomyopathy. Now, I have said you the clue. Now, tell me the answer. Systemic scleroderma. Very good. That will be anti-topoisomerase. ये जो anti-centromere जो है, that is in localized scleroderma. Right? Whereas anti-topoisomerase, that will be in the diffuse scleroderma. Okay? So the answer is anti-topoisomerase. Next question. The next question is, what is the adverse effect of the drug used for the treatment in the following condition causing restrictive cardiomyopathy? Peptic ulcer, weight loss, distal muscle weakness, dementia. First of all, please tell me the diagnosis. What is the diagnosis of this etiology causing restrictive cardiomyopathy? Yes, फटाफट बोलना. Right. So you can observe here. एक क्या है इधर? What is the abnormality you are making out here? Bilateral hilar lymphadenopathy है. Bilateral hilar lymphadenopathy किस conditions में होगा? Very common condition is sarcoidosis. So sarcoidosis is one of the etiology which will cause the restrictive cardiomyopathy. ये दो स्टेप प्रोसेस है. नहीं, ये दो स्टेप नहीं, तीन स्टेप क्वेश्चन है ये तीन स्टेप क्या है? पहले you should diagnose what is the etiology, sarcoidosis. Second step जो है, what is the drug of choice for sarcoidosis? Steroids. मैंने क्या पूछा? What is the adverse effect of the drug used for treatment in the following condition causing restrictive cardiomyopathy? तो स्टीरॉइड से एडवर्स इफेक्ट क्या है? दैट विल बी योर पेप्टिक अल्सर. दैट विल बी पेप्टिक अल्सर. एंड वेट लॉस नहीं होगा ये पेशेंट्स में, वेट गेन होगा स्टीरॉइड्स की वजह से. और डिस्टल मसल वीकनेस इज नॉट कॉमन, प्रॉक्सिमल मसल वीकनेस इज कॉमन. एंड डिमेंशिया डेवलप नहीं होगा, साइकोसिस डेवलप होगा स्टीरॉइड ज्यादा होने की वजह से. ठीक है? सो ये जो आंसर है दैट इज पेप्टिक अल्सर. देन इन दीज पेशेंट्स, right, in these patients with restrictive cardiomyopathy, thromboembolic complications are common. Right? Why? Because these patients with restrictive cardiomyopathy, they will develop atrial fibrillation. तो atrial fibrillation के वजह से thromboembolic complications are very very important. Then very important in the restrictive cardiomyopathy is about the JVP. So there will be elevated JVP. Kussmaul sign will be present in restrictive cardiomyopathy. X and Y descent. Okay, X and Y descent will be exaggerated. That will be JVP findings in patients with the restrictive cardiomyopathy. Then how will you diagnose restrictive cardiomyopathy? Yes, first line investigation जो है that will be 2D echo. Then what will the ECG show? ECG in case of restrictive cardiomyopathy, that will show you that there is low voltage complexes. Right? What do you mean by low voltage complexes? The amplitude of the QRS complex will be less than 10 mm in the limb leads, less than 5 mm in the chest leads. That is called low voltage complexes. You will have that in restrictive cardiomyopathy. And what is the first line investigation I have taught you? First line investigation will be 2D echo. Right? Now, what is that you will observe in the 2D echo? You will have this particular dotted appearance. Right? You will have this particular dotted appearance in the 2D echo. अगर dotted appearance है, that means it is an infiltration. What is that? That is your amyloidosis. Right? That will be amyloidosis. Okay? So that will be echocardiography. Okay? Then, or we call this dotted appearance को हम दूसरा terminology क्या use कर सकते हैं? Speckled pattern. We call this as speckled pattern. And the remaining all will be same. That is, there will be heart failure with preserved ejection fraction. Diastolic dysfunction will be there. And your atrial dilatation will be there. Okay, your atria is abnormally dilated. Why? Because your diastolic pressures of the ventricles are increased. So your atrial distension will be there. Then how will you treat these patients with the restrictive cardiomyopathy? Ultimately, these patients will develop the features of heart failure. So you need to give the diuretics. And I said you, these individuals, they also have thromboembolic complications. So because of this thromboembolic complications, we give anticoagulants like low molecular weight heparin, or oral anticoagulants that you can give is warfarin, can be given in patients with the restrictive cardiomyopathy. One important question है कि digoxin use कर सकते हैं क्या restrictive cardiomyopathy में? Any one of you? Because atrial fibrillation है, सर मैं digoxin देता हूं, digoxin दे सकते हैं क्या RCMP patients में? Any one of you? Very good. There you should not give digoxin. Why? Why we should not give digoxin? Why we should not give digoxin? That is because digoxin will precipitate arrhythmias. That is the reason why don't give digoxin. Okay, so that is about your cardiomyopathy, right? So we have discussed dilated, we have discussed hypertrophic, we have discussed restrictive cardiomyopathy as well. Yes, all of you, are you comfortable until now? Yes, Harjeet, arrhythmias PPT I will send you, and even I will discuss arrhythmias separately. All of you, are you comfortable? Is everything going on well? Do you want any changes to be done? Right, ठीक है. If everyone is comfortable, अच्छा, understood Harjit. Yes, it precipitates arrhythmias. Got it. ठीक है. Now, the next important topic is the heart sounds. Right. Answer this question. Which is the location of Erb's point during auscultation? The next topic will be heart sounds. Yeah, this particular video will be available even after the class. This particular video will be available even after the class. Very good, superb. Right. So Erb's point is third left intercostal space. Okay. So like let us just assume this is 1, second, and this will be third. Okay. So third left intercostal space will be the Erb's point. And this Erb's point, it is the best site for auscultating which heart sound? Any one of you? Yes, Which particular heart sound you can listen best at the herbs point? Any one of you? That is the second heart sound, right? Second heart sound is heard best at the herbs point. Okay, right? Then, having discussed about the heart sounds, that is areas of auscultation. What are the various areas of auscultation? A stands for aortic area. P stands for pulmonary area. Aortic area, where exactly is it? It is present in the second right intercostal space adjacent to the sternum. Pulmonary area, left second intercostal space adjacent to the sternum. Erb's point, that is third left intercostal space adjacent to the sternum. Tricuspid area, that is fourth left intercostal space adjacent to the sternum. Mitral area, it corresponds to the apex. Mitral area, it corresponds to the apex. Right? One important question that they will ask you is, during which phase of cardiac cycle you listen this heart sounds? S1. Yes. Which phase of the cardiac cycle you will listen this first heart sound? Any one of you, please? First heart sound is heard during, yes, anyone? Isovolumetric contraction phase. What about S2? What about S2? It is heard during isovolumetric relaxation phase. Okay? What about S3? Isovolumetric relaxation or during protodiastole. Anything is fine. Anything is correct. S3 is heard during which phase? That is first rapid filling. Right? That is first rapid filling. And S4 is heard during which phase of the cardiac cycle? That will be second rapid filling. That is due to atrial contraction. Right? That is due to atrial contraction. Okay? Right. फटाफट से हम all the heart sounds को compare करेंगे हम. ठीक है? Right. Let us compare all the heart sounds now. If you take the character, first heart sound is a high pitched sound. Second is also high pitched sound, whereas your third and fourth, they are low pitched sounds. Duration क्या होगा? First heart sound का duration क्या है? जो है 0.14 second. And second heart sound, it is 0.11 second. And third and fourth, it is 0.10 second. Frequency. The question that will be asked is the heart sound with highest frequency. That will be the second heart sound, 50 hertz. फिर फर्स्ट हार्ट साउंड का फ्रीक्वेंसी कितना है? 25 to 45 and the remaining will be less than 20. क्वेश्चन क्या पूछेगा आपको? The one with highest frequency. So what will be the cause? Right? First heart sound का जो cause है, that is vibrations which are generated within mitral and tricuspid valve. Okay? Vibrations which are generated in mitral and tricuspid valve. Whereas second heart sound, it is due to closure of aortic and as well as pulmonary valve. Third heart sound, it is due to rapid ventricular filling, that too first rapid filling. And fourth heart sound, it is second rapid ventricular filling. Right? Timings already I have said you. Isovolumetric contraction phase, isovolumetric relaxation phase, first rapid filling, second rapid filling. Right? उसके बाद how do you listen this? First heart sound is heard with diaphragm. Second heart sound, it is heard with diaphragm. Why? जो भी high pitched sounds, that you will listen them with diaphragm. अगर low pitched sounds है, then you will listen that with a bell. Okay? Low pitched sounds, you will listen that with a bell. Right? And one important question is regarding the second heart sound. Second heart sound थोड़ा important है. Wide split S2 occurs in, any one of you? Wide split S2 occurs in. Very good. You have two answers. दो answers है आपको. एक होगा ventricular septal defect, second होगा atrial septal defect. So wide split S2 occurs in BSD and as well as ESD. Now let me tell you all the conditions where you will have wide split S2. वाइड स्प्लिट S2 किस वजह से हो सकता है? एक होगा that is because of early A2 or because of delayed P2, you can have wide split S2. So early A2, you will have that in MR, you will have that in VSD. Delayed P2, you have that in atrial septal defect, you have that in pulmonary embolism, right? And you also have that in pulmonary hypertension. And you also have that in right bundle branch block. You will also have that in left ventricular ectopic beats. And you will also have that in left ventricular paced beats. So these are all the conditions where you will have wide split. Wide split has to either early A2 के वजह से हो सकता या delayed P2 के वजह से हो सकता. It can be due to early A2 or delayed P2. Next, very important question. अगर हार्ट साउंड सेकंड हार्ट साउंड के ऊपर अगर क्वेश्चन पूछना है, if the question is asked on second heart sound, please keep this in your mind. Causes of wide fixed split are all except, the question asked except. Very good, Narsimha. The answer is VSD. So VSD, you will not have wide fixed split. You will have wide variable split. Right? You will have wide variable split. Okay? Right. Next question. S2 is best appreciated in. S2 is best appreciated in. Just now we have answered it. S2 is best appreciated in the Erb's point. What is Erb's point? That is third left intercostal space. That is the Erb's point. Okay? Next question is, third heart sound is best heard with. Option A is bell. Option B is your head. Option C is the diaphragm. Option D is tubing. Third heart sound is best heard with. Any one of you? Very good. That is heard with the bell of the stethoscope because it's low pitched sound. Okay. Next question. Third heart sound is best heard at. What is the area of auscultation where you will listen this best? Yes? No. Not at the Erb's point. Not at the Erb's point. Third heart sound जो है, it is heard best at the apex. What is apex? Apex is nothing but your mitral area. So in the mitral area, you will listen third heart sound as best. Next, physiological S3 is heard in all except. Physiological S3 is heard in all except. Very good, Barad. Sumo fighters. Sumo fighters, you cannot listen S3 because S3 जो है low pitched sound है. Sumo fighters कैसे रहेगा? Obese, ये low pitched sound, obese individuals, can you listen that? 9. The remaining all, you will have this physiological S3. Then, what are the causes for pathological S3? Causes for pathological S3, right ventricular failure, left ventricular failure, any condition causing right ventricular failure and left ventricular failure, right? And even your ischemic heart diseases, even your valvular heart diseases like MR and AR. So these are all the conditions where you will have pathological S3. Then next, coming to the fourth heart sound. Fourth heart sound is what it is. If it is heard, it is always pathological. You don't have physiological S4 at all. Then what are the conditions where you will have this pathological S4? And if at all, if you are listening, you will listen that at the apex, right? You will listen that at the apex, right? And why is this? Due to forceful atrial contraction. Where will you have that forceful atrial contraction? Right? This is the mnemonic. Mnemonic is what? Hypertrophic obstructive cardiomyopathy. The word H stands for HOCM or hypertension. O stands for obstruction other than HOCM. That is aortic stenosis, pulmonary stenosis. The word C stands for cardiac clamp. The word M stands for myocardial infarction. So these are your 4 important heart sounds. Heart sounds are not over without discussing the added sounds, right? The added sounds are ejection click, opening snap, pericardial knock, tumor plop. Okay, where will you have this ejection click? Any one of you, please? Any one of you? Where will you listen this ejection click? Ejection click, you will listen that in aortic stenosis and pulmonary stenosis, and it is a high pitched sound. Opening snap, where will you listen this? You will listen this in mitral stenosis and tricuspid stenosis, and this is also a high pitched sound. Pericardial knock, you will listen that in constrictive pericarditis, and that is also a high pitched sound. Tumor plop, you will listen that in atrial myxoma. In atrial myxoma, you will listen the tumor plop. Tumor plop high pitched sound hai kya? No, 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 no. It is a low pitched sound. So, among all these, which is the low pitched sound? Tumor plop. And next important is your ejection click जो है a systolic sound है. The remaining all are your diastolic sounds. देखो, how many questions are there in this table? There are almost 10 questions which can be asked in this particular table itself. Okay, so this table is very very important related to your added sounds. ये हो गया आपका hard sounds का discussion. First, second, third, fourth and added sounds. Then next important topic क्या है? JVP, jugular venous pulsation. Jugular venous pulsations में there are 5 important waves. A wave, that is due to atrial contraction. C wave, that is due to bulging of the cusp into right atria. X wave, that is due to atrial relaxation. V wave, that is due to venous filling. Y wave, that is due to atrial emptying. You know what will be the questions that will be asked? Questions is that they will try to correlate with the cardiac cycle. A wave, which phase of the cardiac cycle? A wave is what? Atrial contraction. Atria contract होने के समय में ventricle क्या कर रहे? Ventricle is in a phase of end diastole, right? Mechanical event is atrial contraction. C wave, that is tricuspid valve bulging into the right atrium. What is your ventricle doing? Ventricle is in early phase of the systole. Then X wave. X wave is what? Atrial relaxation. Atria relax होने के समय में ventricle क्या कर रहे? That it is in the mid part of the systole. Then V wave. V wave is what? Venous filling. Venous filling होने के समय में atria ventricle क्या कर रहे? That it is in the late part of the systole. Y wave is what? Y wave is the atrial emptying. Atria empty होने के समय में ventricle क्या कर रहे? Ventricle is in early diastole. This table is very very important. This table is very very important. Okay? Then now let me discuss abnormalities of the waves. Right? So abnormalities of the waves is the abnormalities of the A wave. Right? So in which condition the A wave is absent? Any one of you please? These conditions में atrial A wave is absent. Very good Abhay. That is atrial fibrillation. Then in which condition you will have a giant A wave? Giant A wave you will have that in case of right atrial myxoma. You have that in tricuspid stenosis. You have that in pulmonary hypertension. Next important thing is Canon A wave. Where will you have Canon A wave? Canon A wave, you will have that in complete heart block. You will have that in case of junctional rhythm. Right? So these are the conditions where you will have Canon A wave. Okay? Right. After abnormalities of the A wave, next thing is abnormalities of the X wave. So X wave का abnormalities क्या है? X wave is exaggerated. In which conditions the X wave can be exaggerated? That is in restrictive cardiomyopathy, constrictive pericarditis, and then cardiac tamponade. These are the conditions where the X wave is exaggerated. What are the conditions where X wave is reversed? X wave is reversed in tricuspid regurgitation. These are the abnormalities of X wave. What are the abnormalities of the V wave? V wave is increased. Where is the V wave increased? That is in tricuspid regurgitation. And lastly, abnormalities of the Y wave. So, what are the conditions where the Y wave is absent? That is in case of cardiac tamponade. Where is that you have early Y wave? Early Y wave, you have that in tricuspid regurgitation. Where will you have exaggerated Y wave? Exaggerated Y wave, you have that in restrictive cardiomyopathy and constrictive pericarditis. And where is that you will have slow Y descent, that you will have in tricuspid stenosis. These are the abnormalities of the wave. ये याद रखना है क्या? Yes, you have to remember all these abnormalities. Anything can be asked. Last important point about JVP is Kussmaul sign, Kussmaul respiration. Right. What is Kussmaul sign? Kussmaul sign is increase in the jugular venous volume on inspiration. Right. Where will you have this? You will have this in all the conditions which will cause the right heart failure. You will have this in constrictive pericarditis. You will have this in restrictive cardiomyopathy. Is it present in cardiac tamponade? No. Cardiac tamponade में Kussmaul sign is absent. Very, very important point. Next, coming to the Kussmaul's respiration. Yes, Kussmaul's respiration. Any one of you? Diabetic ketoacidosis, right? You will have Kussmaul's respiration in diabetic ketoacidosis. Okay? So that is about your JVP. In 5-10 minutes, the entire JVP is done. Right. Now, so as of now, is everything fine? Do you want any changes to be done? I see some of the students falling down. Why the number is reduced? Any changes that has to be done from my side? Okay. All fine. Right. Now, next important topic is the arterial pulse. Arterial pulse. You should know pulse में what are the questions that will be asked for you. So in the pulse, the questions that they will ask you is the abnormal characters of the pulse. First important is pulsus paradoxus. Any one of you pulsus paradoxus? Where will you have, which cardiac condition you will have pulsus paradoxus? You will have that in cardiac tamponade, right? And occasionally in constrictive pericarditis. Occasionally constrictive pericarditis. Pulsus alternans. Any one of you pulsus alternans? Pulsus alternans, you will have that in severe left ventricular failure. Where will you have electrical alternance? Any one of you please? Which condition you will have electrical alternance? Yes, electrical alternance किस conditions में रहेगा? Electrical alternance जो है, it is the ECG finding. Electrical alternance is not a pulse, it is a ECG finding. Anyone? I'm waiting for the answer. Very good, Narsimha. In case of massive pericardial effusion, you will have this electrical alternance. Okay? Then pulsus parvus et tardus. Where will you have pulsus parvus et tardus? Very important. That is in aortic stenosis. What is pulsus parvus et tardus? It is a slow rising pulse with late peaking. That is called pulsus parvus et tardus. Pulsus bigeminus. ये तो आंसर करना है. Pulsus bigeminus. Any one of you please? Because pulsus bigeminus, it is due to a drug toxicity. Anyone? Which particular drug toxicity will cause ventricular bigeminy? It is an integration with pharmacology and medicine. Very good, Narsima. That will be digoxin toxicity. Digoxin toxicity may you will get pulses bigeminous. Then the other important character of the pulse is the water hammer pulse. Where will you have water hammer pulse? You will have that in aortic regurgitation. There are many other conditions. Even in MR, you can have this water hammer pulse. But which important cardiac condition? That is AR. Then next is dicrotic pulse. Where will you have dicrotic pulse? Dicrotic pulse, you have that in case of dilated cardiomyopathy. Lastly, where will you have pulsus bispherians? Any one of you pulsus bispherians? Very good. That you will have in HOC. That you will have in HOC. That is about the pulsus bispherian. Okay? Right. Now, we'll move. That is over. That is about the characters of the pulse. Next important question is about the murmurs. Murmurs is a very, very important topic. Murmur ka, without revising murmurs, don't go to the exam. Don't go to the exam without revising the murmurs. Okay? Right. So yes, which condition following murmur is seen? Aortic regurgitation, ASD, transposition of the great arteries, branched pulmonary artery stenosis. Fatafat, any one of you? I am not getting. Very good, Abhay. Abhay has answered it. That is in case of. First of all, what murmur is this? This is a continuous murmur. Why is it called continuous murmur? Because throughout the cardiac cycle, starting from S1, passing through your S2, again ending at S1. So throughout the cardiac cycle murmur है, इसलिए इसको continuous murmur बोलते हैं हम. What are the important conditions causing cardiac murmurs? Sorry, continuous murmurs. Patent ductus arteriosus, ruptured sinus of Valsalva, AV fistula, which is very, very important condition. Then venous hum. Then you will have in pregnancy, that is mammary souffle. Then branched pulmonary stenosis, right? Branched pulmonary stenosis. Then any other condition? Yes, we also have this over the occlusions, that is carotid artery occlusion, renal occlusion, coarctation of aorta, coronary occlusion, femoral occlusion. All these you have the continuous murmurs. Okay, right. Then continuous murmur discussion होने के बाद, yes, please identify this murmur. ये टू स्टेप प्रोसेस है. पहले मर्मर आइडेंटिफाई करना, उसके बाद which condition you will have this murmur is very, very important. Yes, please identify the murmur. The murmur is, okay, very good, Jinesh. But what is this murmur? This murmur, it is a pansystolic murmur because it is present in between S1 and S2 and that too throughout the systole. पूरा systole में ये disturbance है. फिर इसको क्या बोल सकते हैं हम? Pansystolic murmur. Pansystolic murmur किस conditions में रहेगा? You will have that in case of VSD. You will have that in MR. You will have that in TR. Right? So the answer is VSD. Okay? Then next important is, yes, identify this murmur and in which condition you will have this. Identify this murmur, in which condition you will have this. So what is this murmur, my dear students? First of all, ये murmur जो है, very good Shashi, that is late systolic murmur, right? Because you have a peaking in the late part of the systole. So which condition you will have late systolic murmurs? You will have that in MVPS and as well as the TVPS. So the answer is A. Okay? Right. The next important is, yes. First of all, please identify this murmur and tell me in which condition you will not have this murmur. The question जो पूछा है, except. Identify the murmur. Very good. It is a mid-systolic murmur which is also called ejection systolic murmur. Which all conditions you will have this mid systolic murmurs? AS, mid systolic murmur. PS, mid systolic murmur. HOCM, mid systolic murmur, but not in case of TS. TS, what is a murmur? TS में murmur क्या होगा? That will be mid diastolic murmur. So tricuspid stenosis में you will have the mid diastolic murmur. ठीक है? Next. So continuous murmurs done. Systolic murmurs done. What is that we are left out with? We are left out with the diastolic murmurs. Early diastolic murmur is seen in. Early diastolic murmur is seen in. So early diastolic murmur, it is seen in AR and as well as PR. So the answer is aortic regurgitation. Then the next important is the mid diastolic murmurs. Where will you listen this mid diastolic murmurs? You will listen that in MS and as well as TS. So we are done with the systolic, diastolic and continuous murmur. You know what is the next important thing? Next important thing जो है named murmurs. Named murmurs is a very important area for the questions. Okay. Now, Carey-Coombs murmur. Any one of you, where will you listen the Carey-Coombs murmur? Carey-Coombs murmur, you will listen that in acute rheumatic fever. Acute rheumatic fever mein you will have this Carey-Coombs murmur. Why? Because of acute mitral regurgitation. Austin Flint murmur, where will you listen? And Carey-Coombs murmur, not only in acute rheumatic fever, you also listen that in VSD and you also listen that even in PD. Okay. Austin Flint murmur, very good. That is in aortic regurgitation. Next important is Graham-Steele's murmur. Where will you listen this Graham-Steele's murmur? You will listen this Graham-Steele's murmur in pulmonary hypertension causing pulmonary regurgitation. Pulmonary hypertension causing pulmonary regurgitation. Then Reitand's murmur. You will have that in case of complete heart block. Dock's murmur. You will have that in left anterior descending artery stenosis. Millville murmur. You will have that in air emboli. Then lastly, Gibson's murmur. Where will you listen Gibson's murmur? That is PDA, patent ductus arteriosus. So named murmurs, very important area for your questions. ठीक है? Murmur का topic खत्म हो गया. The next important is the valvular heart disease. So valvular heart diseases में the first is mitral stenosis. Yes, murmurs. Is it done, all of you? Can you remember now all the murmurs? Continuous, systolic, diastolic, named murmurs. Okay? Then coming to the, see, your LAD stenosis, you will have diastolic murmur. Dock's murmur, it is a diastolic murmur. Right? Whenever there is LAD stenosis, when will the heart receive the blood? The heart will receive the blood during diastole. So during diastole, if there is any stenosis of left anterior descending artery, there will be a murmur that will be produced during diastole. That is what is your Dock's murmur. ठीक है नरसिम्हा? Right. Okay. Now the next is area of mitral orifice. Very simple and easy question. That is 4 to 6 centimeters square. Now, depending upon the valve area, I'll show you a table. Don't get confused by the entire bulk of the table. What is important in that, I'll tell you. Right. So, इसमें important points जो है, when will you call it as very severe mitral stenosis? Very severe mitral stenosis is that when the valve area is less than 1 centimeter square. When will you call it as severe mitral stenosis? When the valve area is less than or equal to 1.5 centimeter square. When will you call progressive mitral stenosis? When the valve area is more than or equal to 1.5 centimeter square. Then mitral stenosis का important etiology क्या होगा? What is the important etiology causing mitral stenosis? That will be rheumatic fever. Rheumatic fever is the most common cause for mitral stenosis. The remaining all other etiology, you can see that mitral annular calcification, parachute mitral valve or congenital mitral stenosis, systemic lupus erythematosus and rheumatoid arthritis, and storage disorder, that is mucopolysaccharidosis, that is Hurler syndrome. But most common cause जो है rheumatic fever. ठीक है? Then auscultation is very very important in MS. First heart sound कैसे रहेगा? That will be loud. Do you have soft S1 in MS? Yes. Where will you have soft S1 in MS? Agar mitral stenosis, if it is calcified, then you will have soft S1. Then how will be S2? S2, the P2 will be loud. Additional heart sound क्या है? What is the additional heart sound in mitral stenosis? Between S2 and S1, that is called diastolic phase. Between S2 and S1, you will listen a mid-diastolic murmur, and in early part of the diastole, you will listen an opening snap, and in late part of the diastole, you will have pre-systolic accentuation. This will be the auscultation in case of MS. Then, after this, why this P2 will be loud? Why this P2 will be loud? P2 will be loud because mitral stenosis patients का एक important complication है कि pulmonary hypertension. Because of pulmonary hypertension, the P2 will be loud. Then, what are the complications of mitral stenosis? Mitral stenosis complications are atrial fibrillation, dysphagia, wheeze, and Ortner syndrome. Ortner syndrome is the question. Any one of you, what is Ortner syndrome? Ortner syndrome is the question. Any one of you, what is Ortner syndrome? Ortner syndrome is there will be compression of recurrent laryngeal nerve causing hoarseness of voice. Right? The dilated left atrium will compress the recurrent laryngeal nerve. Whenever the recurrent laryngeal nerve is compressed, there will be hoarseness of voice. Okay? That is called as the Ortner syndrome. Then how will you diagnose mitral stenosis? Diagnosis of mitral stenosis, ECG से अब diagnose कर सकते हैं क्या? Yes, we can diagnose. Any one of you, what will be the ECG finding in MS? Yes. The ECG finding in mitral stenosis is that you will have the P mitral. Why is this P mitral? Due to this particular P mitral is due to left atrial hypertrophy. Right? That is due to left atrial hypertrophy. So that is what is your P mitral. Then chest X-ray का findings क्या है mitral stenosis में? There will be straightening of the left heart border. Normally left heart border straight रहता है क्या? No. Left heart border you have the curvature. But because of your left atrial dilatation or left atrial hypertrophy, you will have straightening of the left heart border. And another very very important finding is double density sign. What is this double density sign? You see, this is one shadow on the right side and this is the second shadow on the right side. And this double density sign is also due to what? That is also due to left atrial dilatation. Okay? Then, what is the important finding in the 2D echo? In the 2D echo, you will get this classical hockey stick appearance. Why is this hockey stick appearance? That is due to restricted anterior mitral leaflet mobility. You get this hockey stick appearance. Now, can anyone tell me where will you get hockey stick appearance in the ECG? Where will you get hockey stick appearance in the ECG? Anyone? Very good, Galva. That will be the digoxin effect. In digoxin effect, you will have this hockey stick appear. Okay? In ECG, a 2D echo में mitral stenosis. Right. Yeah. Narsima is asking, sir, which is right atrium, which is left atrium? Okay? So, this is left atrium. This is right atrium. Normally, left atrium नहीं दिखेगा आपको. क्यों? Left atrium is present behind the sternum in a normal individual. So left atrium is normally not seen. but because of left atrial enlargement, you are able to see the left atrium in the right parasternal area, and that is giving you the double density sign. Then mitral stenosis patients में treatment क्या होगा? What will be the treatment? So treatment is that salt restriction and as well as diuretics. क्यों? Because mitral stenosis patients में clinical features क्या होगा? Dyspnea. Why dyspnea? That is because of increase in your pulmonary capillary wedge pressure causing pulmonary edema. So you give diuretics. Next question is very, very important. Any one of you, which procedure is being done in the image shown? Which procedure is being done in the image shown? Yes. Which particular procedure is being done? Right. That is nothing but your, yes, percutaneous mitral balloon valvotomy. So what is the indication for PBMV? If there is severe or very severe mitral stenosis, and along with that there are symptoms of mitral stenosis, then it's an indication for PBMV. And you should also know what are the contraindications for PBMV. अगर valve is calcified, don't do PBMV. If there is left atrium having thrombus, don't do PBMV. And if MS is associated with moderate to severe MR, don't do PBMV. So these are the contraindications for PBMV, right? That is percutaneous mitral balloon valvotomy. ठीक है, right? And ये पूरा conditions में फिर क्या करना है? You should directly do mitral valve replacement, right? You should directly do mitral valve replacement because you cannot do PBMV in those patients, so you have to do mitral valve replacement. Done. That is about mitral stenosis. The next important valvular pathology is MR, mitral regurgitation. You should know the important cause of MR. The important cause of MR is mitral valve prolapse. Then the remaining all, rheumatic fever, infective endocarditis, mitral annular calcification, or we also have secondary MR. Secondary MR जो है, it is secondary to coronary artery disease, dilated cardiomyopathy, restrictive cardiomyopathy, papillary muscle dysfunction, that will be secondary MR. And you know what is the important question in the MVP? That is, right, to call it as mitral valve prolapse, right, to call it as mitral valve prolapse, how much like mitral valves should prolapse into the left atrium by, mitral valves should prolapse into the left atrium by how much mm? How much mm? That is by 2 mm. That is a multiple choice question. So from the baseline, of the mitral valve annulus, the mitral valve has to prolapse by 2 mm into the left atrium. That is called mitral valve prolapse. Okay? Right. And in mitral regurgitation, what will be the symptoms? The most common symptom will be dyspnea. Why dyspnea? That is due to pulmonary venous congestion. And there will be fatigue. Why fatigue? Because cardiac output kahan hai? Where is the cardiac output? When the left ventricle is contracting, the blood is going into left atrium, so cardiac output is reduced, so they will have fatigue. And these patients with MR, they land up in heart failure with reduced ejection fraction, so they will have an additional heart sound, that is S3. What about the murmur? Murmur already I have discussed, that is pansystolic murmur. Where will you listen this murmur? You will listen this murmur at the apex of the heart. Where it will radiate to? It will radiate to the axilla. Okay. Do you have any abnormalities of the heart sounds? Yes. What is that abnormality? The first heart sound will be soft. And if there is development of pulmonary hypertension, even your P2 also can be loud. Right? Even there is pulmonary hypertension, even your P2 can be loud. So soft S1, loud P2, S3 will be there if there is left ventricular failure with pansystolic murmur. Okay? So that is about your MR auscultation. For MR, how will you diagnose? Diagnosis is by your 2D echo. That will be the indication, that is the first line investigation in mitral valve regurgitation. Then treatment क्या देना? These patients are developing heart failure, so you give diuretics. Mitral valve replacement करना है क्या? Yes, you have to do mitral valve replacement. There are certain indications for mitral valve replacement. What are those indications? Those indications are when there is ejection fraction of the left ventricle less than 60% with MR, then you should do mitral valve replacement. Or when left ventricular end systolic dimension, if it is less than 45 mm, then also you need to do mitral valve replacement. Okay, so mitral valve replacement का जरूरत रहेगा MR patients में when ejection fraction less than 60% or left ventricular end systolic diameter, I'm sorry, left ventricular end systolic diameter more than 45 mm, right? More than 45 mm. ठीक है, this completes your MR. Then next important is the aortic valve diseases. Aortic valve diseases, only 2 minutes I'll finish aortic valve. That is AS, aortic stenosis. That is most common cause of aortic stenosis in children. First of all, how much is the normal aortic valve area? Normal aortic valve area is 3 to 4 centimeters square. When will you call aortic stenosis? When the valve area is less than 2 centimeters square, we use the word aortic stenosis. Then what is the etiology? Children में aortic stenosis हो सकता है क्या? Yes. What is the most common cause? Bicuspid aortic valve, right? And what is the most common cause in adults? That will be sclerotic aortic valve. फिर aortic stenosis में what will be the clinical features? Just remember the mnemonic, that is SAD. SAD में क्या है? Shortness of breath. A stands for angina, right? And S is your syncopal attack. Okay. D stands for dyspnea. Syncopal attack, angina, dyspnea, right? Then examination, what is very, very important? If you take the pulse pressure, you will have a narrow pulse pressure. Why you will have narrow pulse pressure? Because systolic blood pressure is reduced. So that is the reason why you will have narrow pulse pressure. Auscultation में कुछ problem है क्या? Yes. The second heart sound, it will be soft. That particularly A2 component. फिर murmur क्या होगा? Murmur will be the ejection systolic murmur. Murmur will be ejection systolic murmur. If the patient is symptomatic, what will you do? You have to do surgical correction of the valve. Valve replacement you have to do, right? See, these type of some quick pointers you can see on my Instagram handle, right? My Instagram handle will be, or it is Rajesh Gubba, right? So you can follow me on my Instagram for this quick pointers of the various topics which will be useful for your final quick revision, right? So this is about your AS, aortic stenosis. Then followed by that, last important valvular lesion will be AR, aortic regurgitation. Answer this question, aortic regurgitation does not occur in. Aortic regurgitation does not occur in. Does not occur in acute myocardial infarction. In acute myocardial infarction, what you can have is MR, but not AR. Whereas Marfan's, rheumatic heart disease, infective endocarditis, you can have aortic regurgitation. In fact, what is the most common cause of AR? The most common cause of AR will be rheumatic heart disease, right? And your Marfan's, it's a connective tissue disorder. Osteogenesis imperfecta, Ehlers-Danlos syndrome, you can have AR. And even some connective tissue disorders like ankylosing spondylitis, you can have this aortic regurgitation. Sexually transmitted disease, syphilis, can cause this aortic regurgitation. Aortic regurgitation में important points क्या है? Very, very important is the peripheral signs. See, there are almost like 10 to 15 peripheral signs, But what is very important, I will just summarize here. एक होगा Corrigan's pulse, which is nothing but your Wertheimer pulse, which is also called collapsing pulse. Next thing is Demusset sign. Demusset sign is head nodding with each cardiac cycle. That is called Demusset sign. Muller sign. What is Muller sign? It is the pulsations in the uvula with each cardiac cycle. That is called Muller sign. Quincke's sign. What is Quincke's sign? Pulsations, capillary pulsations over the nail bed. That is called Quincke's sign. Then Traub sign. What is Traub sign? Traub signs are nothing but the pistol short sounds over the femoral artery. That will be the Traub sign. Next thing is Durosi's sign. What is Durosi's sign? It is the murmur which is heard over the femoral artery. That is systolic and diastolic murmur. That is called Durosi's sign. Then the Hill sign. What is Hill sign? Systolic blood pressure in the femoral artery is more than the brachial artery by more than 20 millimeters of mercury. That is what is your Hill sign. And Hill sign also tells you about the CVRP. Agar systolic blood pressure in femoral artery is more than 60 millimeters of mercury in the femoral artery than compared to brachial artery. मान लीजिए like femoral artery में systolic blood pressure जो है it is something like 200, right? And brachial artery में systolic blood pressure is something like 130. It is called severe AR. It is called severe AR. So that is about the important peripheral signs. Actually, you have many peripheral signs. What are very important I have discussed. And you know what is very important point? All these peripheral signs are present only in chronic AR. You will not have them in case of acute AR. In acute AR, you don't have peripheral signs. You have peripheral signs only in chronic AR. Then how do you treat these patients with AR? These AR, these patients, they are landing up in left ventricular failure. So the standard treatment of left ventricular failure, diuretics de do. Once pulmonary edema is not there, you can give ACE inhibitors or ARBs and then aldosterone antagonists. One question is, can you give beta blockers in AR? Can you give beta blockers in AR? Any one of you? Please tell me this point. Can you give beta blockers in AR? The answer is no, because when you give beta blockers, the aortic regurgitation will further get precipitated. Why? Because beta blockers will increase the diastolic time. So that is the reason why AR, no beta blockers. Okay? Right. Then, when will you do aortic valve replacement? Aortic valve replacement you have to do when the ejection fraction is reduced to less than 55%, or when the left ventricular end systolic diameter is more than 55 mm, then you have to do aortic valve replacement. Okay? So that is done about your aortic regurgitation, and this finishes your valvular heart diseases. MS, MR, AS, AR. These four valvular heart diseases are important. And just remember the points what I have discussed, that will be more than enough. The next important is the pericardial disorders. So in the pericardial disorders, what is very important is acute pericarditis. And you know what is a very important question? What is the most common cause of acute pericarditis? The most common cause of acute pericarditis jo hai, it is in viral origin. What is that viral infection? Any one of you? Which particular viral infection you will have this pericarditis? The most common virus will be Coxsackie A and as well as Coxsackie B virus. Most common. Then followed by that ecovirus. Then pericarditis may, what will be the signs and symptoms? You have a triad. What is the triad? Triad hoga aapka, one important point is chest pain. And this particular chest pain, it is a pointed pain, and this chest pain increases with inspiration. Then on auscultation, you will listen a pericardial rub, and you have some peculiar ECG findings. What will be the peculiar ECG findings? Let me tell you that now. That peculiar ECG findings will be, there will be global ST segment elevation except AVR, right? And that too, it will be concave ST segment elevation. Then along with that, there will be PR segment depression. That will be global PR segment depression except AVR. Okay, so this will be the peculiar ECG findings. What will you give treatment? It is pericarditis. Itis is what? Inflammation. So what will you give? Anti-inflammatory drugs. What are those anti-inflammatory drugs? You give high dose aspirin, right? You give high dose aspirin, right? अगर aspirin से काम नहीं हो रहे, the patient is not getting better with your aspirin, then फिर क्या दे सकते हैं? Steroids दे सकते हैं. You can give steroids. They are also anti-inflammatory drugs. So that is about your acute pericarditis. Done. The next important topic will be the constrictive pericarditis. So what is the definition of the constrictive pericarditis? The definition of the constrictive pericarditis is that the pericardium, it will be thick and as well as scarred. Thick, scarred, calcified. तो उस वजह से प्रॉब्लम क्या होगा? प्रॉब्लम जो है, the ventricles are unable to relax because pericardium is thick and scarred and calcified. So do you think that the ventricles can relax? No, ventricles cannot relax in case of constrictive pericarditis. So what type of dysfunction will be this? This will be diastolic dysfunction. So then what is the most common cause of constrictive pericarditis? Most common cause of constrictive pericarditis will be sequelae of pyopericardium. Sequelae of pyopericardium. This pyopericardium can be caused by your tuberculosis as well. Right? This pyopericardium is caused by your tuberculosis. Pyopericardium is what? Pus in the pericardium. The word pyo means pus. Pericardium, pus in the pericardium. That can be caused by your infection. That is tuberculosis. And if this pus is organized, then it becomes constrictive pericarditis. Now, very, very important question related to constrictive pericarditis is square root sign. What is this square root sign? So this particular square root sign, it is a cardiac catheterization finding of pressure changes, right, of pressure changes within the ventricles, right, within the ventricles. That is what is your square root sign. Okay, so whenever the ventricle is relaxing, the pressure drops down, dip. When the ventricular filling is there, there will be elevation in the pressure. So elevation. Now ventricle, do you think that it can completely relax? No, 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 no. Because pericardium is thick and calcified. So this thick and calcified pericardium will not allow the ventricle to completely relax. So immediately there will be a static pressure. That is what is called plateau. So you will have a dip, elevation, and then plateau. So that is what is your square root sign in cardiac catheterization. The next important is the broad bend sign. What is this broad bend sign? It is an apex finding. How will be the apex in constrictive pericarditis? The apical impulse is reduced and it retracts in systole. That is what is called as the broad bend sign. Why is the apical impulse reduced? Because pericardium is thick and calcified, so you cannot feel that particular apical impulse. It is reduced and retracts in systole, and that is called the broad bend sign. Okay? Then auscultation में additional sound क्या होगा? What will be the additional sound? That will be the pericardial knock. And pericardial knock, is it a high pitched sound or low pitched sound? It is a high pitched sound. Is it a systolic sound or a diastolic sound? It is a diastolic sound. That is what is your pericardial knock. Then What will be the ECG finding in constrictive pericarditis? Similar to that of restrictive cardiomyopathy. What did you have in restrictive cardiomyopathy? You had this low voltage criteria or low voltage complexes. The same thing will be there even in constrictive pericarditis. क्यों? Because pericardium is thick and calcified. जो भी इलेक्ट्रिसिटी डेवलप हो रहे मायोकार्डियम में वो पूरा ट्रांसमिट नहीं हो रहे चेस्ट के ऊपर. The entire electrical activity is not getting transmitted onto the surface of the chest. Thereby you get this low voltage calcification or low voltage complexes. Chest X-ray important है क्या? Yes, it is important. Why it is important? When you do a chest X-ray, you will find this calcifications. Right? You see this? A beautiful calcification that you can see. For us it is beautiful, right? But for the patient it is very bad. Okay? So that is the calcification that you can make out in the chest X-ray. Okay? And in the 2D echo, what is that you will find? In the 2D echo, you will find a septal bounce. Right? You will find the septal bounce. The septum, it will be bouncing to the right and left during the inspiration and expiration. And you will have this diastolic dysfunction. Investigation of choice kya hai? What is the confirmatory investigation? The confirmatory investigation is MRI. Right? Confirmatory investigation जो है MRI. MRI में क्या देखना है? What will you see in MRI? You will see that the pericardium is thick. Criteria कितना है? How much should be that increase in thickness? अगर 4 mm से ज्यादा है पेरिकार्डियल थिकनेस, राइट? अगर पेरिकार्डियल थिकनेस 4 mm से ज्यादा है, then it is considered to be constrictive pericarditis. Then it is considered to be constrictive pericarditis. ठीक है? राइट. Then ट्रीटमेंट क्या देना है? वेरी सिंपल. ये डायस्टोलिक डिस्फंक्शन की वजह से प्रॉब्लम क्या होगा? हार्ट फेलियर डेवलप होगा, पल्मोनरी एडिमा डेवलप होगा. यू गिव डायूरेटिक्स, राइट? डायूरेटिक्स ले लिया पेशेंट, सॉल्ट भी नहीं ले रहे पेशेंट, फिर भी डिस्निया है. पेशेंट इज ऑन डायूरेटिक्स, पेशेंट इज ऑन सॉल्ट रिस्ट्रिक्शन, स्टिल देयर इज डिस्निया, राइट? सांस लेने के तकलीफ और भी है डायूरेटिक लेने के बाद भी. देन व्हाट विल यू डू? यू हैव टू डू पेरिकार्डियक्टमी, right? Strip out the pericardium. So when will you do pericardiectomy? Only refractory to medical management. Then you will do pericardiectomy. The next important topic in the cardiology will be hypertension, right? So what is the most common cause of hypertension in adults? Most common cause of hypertension in adults will be essential hypertension. Almost 85% of causes for hypertension will be essential. Essential बोले तो क्या है? Idiopathic. We don't know what is the cause. But 15% they contribute to the secondary. Secondary बोले तो क्या है? There is an underlying cause for the hypertension. Any one of you? Most common cause of secondary hypertension? Most common cause of secondary hypertension? That नहीं renovascular नहीं है, renal parenchymal disease है. Renal parenchymal disease, that will be the most common cause for secondary hypertension. ठीक है? Then उसके बाद होगा आपका causes of isolated systolic hypertension. Isolated systolic hypertension, you will have that in AR. You will have that in case of patent ductus arteriosus. You will have that in case of thyrotoxicosis. In all these conditions, you will have isolated systolic hypertension. And what are the conditions where you will have unequal blood pressure between the right and as well as the left arm? Unequal blood pressure between the right and left arm, you will have that in case of Takayasu arthritis. You will have that in case of coarctation of aorta. You will have that in case of supravalvular aortic stenosis. You will have that in case of aortic dissection. You will have that in case of obstructive aortoarthritis, right? Obstructive aortoarthritis. These are all the conditions where you will have unequal blood pressure between the right and left arm. Sir, normal blood pressure kitna rahna? Normal blood pressure, see, whatever we are following now is your JNC 8. What we are following now is JNC 8. According to JNC 8, adults में blood pressure रहना है less than 140/90. Elderly में blood pressure, elderly बोले तो more than 60 years. Elderly में blood pressure रहना है less than 150/90. अगर comorbidities है, then it is not less than 140/90, it is less than 130/80. अगर पेशेंट को कोरोनरी आर्टरी डिजीज है, डायबिटीज है, सीकेडी है, देन ब्लड प्रेशर शुड बी लेस देन 130/80. ठीक है, मेरा पेशेंट को ब्लड प्रेशर बहुत ज्यादा है, लाइक ही इज नॉट एक्सेप्टिंग दैट, राइट? ही इज नॉट विलिंग टू टेक एनी मेडिकेशन. सर, मेरे पेशेंट को बोल रहे हैं कि अगर टैबलेट नहीं लिए तो ब्लड प्रेशर और ज्यादा होगा और नस फट जाएगा. देन what can you advise first? What is the first important treatment? The first important treatment is lifestyle modification. Lifestyle modification में क्या advice करनी है? एक होगा weight reduction is very very important. दूसरा होगा acquiring the DASH diet. DASH diet बोले तो diet which is rich in fruits, which is rich in vegetables, which is like low fat dairy products. That is called as DASH diet, right? वेट रिडक्शन होने के वजह से कितना ब्लड प्रेशर कम हो सकता? हर 10 kg को 5 to 20 millimeters of mercury कम होगा. For every 10 kgs, 5 to 20 millimeters of mercury blood pressure can be reduced. And by adopting the DASH diet, the blood pressure can be reduced by almost 8 to 14 millimeters of mercury. ठीक है सर, राइट? फर्स्ट लाइन मैनेजमेंट हो गया, राइट? वेट रिडक्शन कर दिया पेशेंट और डैश डाइट भी अक्वायर किया, फिर भी ब्लड प्रेशर और ज्यादा ही है. Then you need to start antihypertensive drugs. So in blacks, right, we Indian population is considered as blacks. So in blacks, what is the first line drug? Either you give diuretic or calcium channel blockers. If at all, if you are giving diuretic, which diuretic will you give? Hydrochlorothiazide. That is, thiazide diuretics are the first line antihypertensive. And in others, right, in all others like whites or you take Caucasians, everything. Along with calcium channel blockers and diuretics, the first line antihypertensives are ACE inhibitors or angiotensin receptor blockers, right? And elderly individuals, the preferable will be your calcium channel blocker. Okay, so now just remember this table for us. This table you remember for us. All ages, what is the first line antihypertensive? Diuretic or calcium channel blocker. Your ACE inhibitor, ARB, they're all second line. Now I am coming up with a very important question. When will you use the word resistant hypertension? When will you use the word resistant hypertension? Any one of you? We use the word resistant hypertension when we are using 3 antihypertensives, and that too full dose of that particular antihypertensives. And in that 3, one should be diuretic, right? In that 3, one should be diuretic. Okay, that is resistant hypertension. Then next is refractory hypertension. Refractory hypertension क्या है? Remember, 4% patients में 4% of patients with resistant hypertension, they can develop refractory hypertension. Refractory hypertension क्या है? Patient is taking more than or equal to 5 antihypertensives, but still the blood pressure is high. That is called refractory hypertension. Okay, right? That is about your topic of hypertension. The last topic in cardiology will be infective endocarditis. What is infective endocarditis? Infective endocarditis is nothing but the formation of the friable vegetations. Where will be these friable vegetations? Over the valves. Now the question is, which of the following is the most friable vegetation? Which of the following is the most friable vegetation? The most friable vegetation, you will see that in case of the infective endocarditis. You will see that in case of infective endocarditis. So according to the friability, if you see the other conditions where you can have vegetations, infective endocarditis, most friable vegetations. Next will be non-bacterial thrombotic endocarditis. Next, rheumatic endocarditis. And which is the least friable vegetations? That will be in your SL, that is Liebman-Sachs endocarditis. Okay? Then, next important is most commonly caused by bacterial endocarditis is most commonly caused by the most common organism causing bacterial endocarditis, the highly virulent organism, that will be your Staphylococcus aureus. That will be Staphylococcus aureus. Very important point is prosthetic valve endocarditis. See, prosthetic valve endocarditis, what is that? There is some problem in the valve. Native valve is being replaced by a prosthetic valve. On that, if there is development of infective vegetation, that is called prosthetic valve endocarditis. इसमें क्वेश्चंस क्या पूछेगा आपको, राइट? व्हाट इज द मोस्ट कॉमन ऑर्गेनिज्म कॉजिंग प्रोस्थेटिक वाल्व एंडोकार्डाइटिस? तो रिमेंबर, एक साल तक द मोस्ट कॉमन ऑर्गेनिज्म इज coagulase नेगेटिव स्टेफिलोकोकाई, राइट? एक साल तक द मोस्ट कॉमन ऑर्गेनिज्म इज coagulase नेगेटिव स्टेफिलोकोकाई, राइट? एक साल होने के बाद द मोस्ट कॉमन ऑर्गेनिज्म विल बी Streptococcus viridans, right? एक साल होने के बाद the most common organism will be Streptococcus viridans, right? Very important question in the infective endocarditis. What is Osler's triad? What is Osler's triad, which is also called Austrian syndrome? You will have pneumonia, you will have meningitis, you will have infective endocarditis. What is the common organism causing Osler's triad? That will be your pneumococcus. That is your Streptococcus pneumonia, right? Then the next important question is, in the infective endocarditis, which one of the following cardiac lesion is at highest risk of occurrence of infective endocarditis? Highest risk. Yes, who will answer this? Right. So the correct answer here will be no. It is not mitral stenosis. It is valvular aortic regurgitation. You need to know this table. Very important table. Please remember, it is very important. Which are the high risk conditions? Aortic regurgitation, aortic stenosis, mitral regurgitation, tetralogy of Fallot, coarctation of aorta, patent ductus arteriosus, ventricular septal defect. These are all high risk lesions for the development of your infective endocarditis, and even prosthetic valve. Which are moderate risk lesions? Moderate risk lesions are mitral stenosis, tricuspid stenosis, pulmonary stenosis, mitral valve prolapse with mitral regurgitation. These are the moderate risk lesions. Which are the low risk lesions? That will be MVP without MR, right? MVP without MR, and then ASD, atrial septal defect. These will be low risk lesions for the development of infective endocarditis. And in infective endocarditis, you need to know some image based questions. The image based questions, what is that you will see in the pulp of the fingers? In the pulp of the fingers, the painful lesions, they are the Osler's nodes. Whereas in the palm and soles, these will be the painless lesions. These painless lesions, they are Roth spots. Sorry, Janeway lesions. I'm very sorry. So, Osler's nodes, painful. Janeway lesions, painless. Okay? Then, you can also have the digital infarct. Digital infarct किस वजह से हो सकता है infective endocarditis patients में? Because small emboli, they can enter into small vessels. When small emboli enter into the small vessels of the digits, there can be digital infarct. Then ये image identify करो please. Please identify this image. Yes, so this will be your Roth spots, right? This will be your Roth spots. Okay. Then what is that retinal hemorrhage in patients with the infective endocarditis? Okay. And what is the name of the criteria? The name of the criteria is Duke's criteria. And you should know the Duke staging. Duke staging we use in carcinoma rectum. Duke scoring we use that in case of chronic stable angina. So this is about your the criteria, name of the criteria. ट्रीटमेंट क्या दे सकते हैं? इन्फेक्शन है, फिर क्या देते हैं आपने? एंटीबायोटिक, which antibiotic you will give? Ceftriaxone plus vancomycin, right? Ceftriaxone plus vancomycin. This is about your infective endocarditis. This finishes the quick revision of your cardiology, right? Medicine, when you compare with other subjects, thoda voluminous hai, right? You have many topics. Even if you take 5 to 10 minutes for one topic, it will take almost like 2 hours, okay? Because in the cardiology, we have nearly around 20 topics. Even if you take 10 minutes each, it will take nearly around 2 hours, okay? Right. So, shall we have a quick break? Shall we have a quick break now? Okay. So you just take a break for 15 minutes. Then we will come and, right, we will come and revise the endocrinology. We will come and revise the endocrinology. Okay? Right. So, yeah, yes, Abhay, the major criteria are the vegetations which is diagnosed by your 2D echo. Next, cultures. How many cultures? More than or equal to 2 cultures should be positive. These 2 will be major criteria. And there are 5 minor criteria. What are those 5 minor criteria? Presence of fever, right? Then immunological phenomenon. Then vascular phenomenon. Then the culture which is not meeting the major criteria, and vegetations not meeting the major criteria. These 5 will be minor criteria. Okay, right. So we will just take a break for 15 minutes. Then we will come back and discuss all these endocrinology topics. Okay, right. Thank you. Please stay until end. Definitely you are going to get 25 marks out of this session. Okay, right. Started. All right. So the next important topic in the quick revision in your medicine will be the endocrinology. So in the endocrinology, these are all the topics which I'll be discussing. So the time which is given for your endocrinology will be like 1 hour. Okay. So within 1 hour, I will revise all these topics. Okay. So stay tuned with me. Definitely, you will get 5 marks in this revision. Right. So in the first topic, that is acromegaly. The first topic will be acromegaly. So acromegaly, what exactly is the problem? It is increase in your growth hormone in adults. That is what is called acromegaly. So how will be the appearance of the individual? So the appearance of the individual is that they will have this frontal bossing. If you take this is the forehead, so there will be frontal bossing. And how will be the nose of the individual? They will have a broad nose. And how will be the jaw? The jaw will be protruded forward. And what is that called as? That is called as prognathism. And if you see the extremities of these individuals, you see they will have a very broad hands. And if you see the foot, they will have the broad foot. And within the fingers, if you see, they have like swollen fingers. And what will be the overall clinical picture in patients with the acromegaly? So, first of all, what is the important etiology that will cause acromegaly? That is somatotroph type of the pituitary adenoma. Somatotroph type of pituitary adenoma, it is the most common cause for your acromegaly. And that too, which type of pituitary adenoma is that? It is macroadenoma, where the size is more than 10 mm. That will be the most common cause for your somatotroph type of pituitary adenoma, which is that macroadenoma. It is not microadenoma. Microadenoma can also cause, but which is more common? Macro is more common than compared to that of micro. Now, what are the important clinical features? The important clinical features will be this macroadenoma will cause the local tumor effect. That means it will cause compression of the optic chiasma, causing visual field defects. And how will be the extremities? There will be acral enlargement, hands and foot enlargement will be there. And musculoskeletal manifestations, just now we have discussed, that is prognathism will be there. Sleep disturbance, why? Because iska tongue, if you see the tongue of these patients with acromegaly, they will have an enlarged tongue. This enlarged tongue will can fall over the respiratory tree during sleep, and that can cause the obstructive sleep apnea. And skin manifestations, they will have a very thick skin, right? And the sweat glands, they will be hypertrophy. So there will be hypertrophy and hyperplasia of the sweat glands. So this hypertrophy and hyperplasia of the sweat glands will result in hyperhidrosis, where there will be profuse sweating. And what will be the gastrointestinal manifestations? That will be in the form of gastrointestinal polyps. And what are the cardiovascular manifestations? That will be left ventricular hypertrophy, hypertension, and then the cause of death in these individuals will be congestive heart failure. All the visceral organs, they are enlarged. Hepatomegaly, splenomegaly, thyroid enlargement, everything will be there. And in case of mammosomatotroph type of pituitary adenoma, they can also have galacturia. And carbohydrate intolerance. So blood glucose levels are also elevated. So what will be the cause of death in these individuals? The cause of death in these individuals will be development of the congestive heart failure. Now, first important question is, what is the best initial test? Any one of you please? What will be the best initial test? Quickly, anyone? Best initial test. Best initial test will be IGF-1 levels, that will be elevated. What is IGF-1? Somatomedin. Somatomedin levels are elevated. Then what is the confirmatory test? The confirmatory test will be growth hormone suppression test. right? Growth hormone suppression test. That will be the confirmatory test. That means failure of growth hormone suppression in spite of glucose load is called as the growth hormone suppression test. Okay, that is a confirmatory test. And then you have some imaging. What is that imaging? This is a very important question. So if you take the x-ray of the digits, what is that you will observe? Isolated, right? Isolated spade shaped phalanx, right? Isolated spade shaped phalanx. Okay, then what will happen to your heel pad thickness? So if you observe the heel pad, there will be increase in the heel pad thickness. How much is the normal heel pad thickness? Normal heel pad thickness जो है ये 13 to 21 mm है. But here in patients with acromegaly, that will be more than 21 mm. So it will be increase in the heel pad thickness. Finally, how do you treat these patients with the acromegaly? The treatment of choice in acromegaly will be transsphenoidal surgical resection of the pituitary. But what will be the problem because of that? The problem is the individual can develop hypopituitary, right? And the primary treatment is always surgery. Then coming to the medical management. In the medical management, what will be the drug of choice? Any one of you? What will be the drug of choice? अगर सर्जिकल ट्रीटमेंट के लिए पेशेंट तैयार नहीं है, then you should give medical management. Drug of choice क्या है? What is the drug of choice? Drug of choice is very good. That is octreotide. Octreotide. Then what are the other alternative drugs that you can give? The other alternative drugs that you can give is bromocriptine. Then what is the second line agent? The second line agent will be pegvisomant. Right? Second line agent will be pegvisomant. Okay. Then next important is, right, terlipressin we don't use here. We don't use terlipressin in case of the acromegaly. Okay. Right. Then next important, you see this question. A patient was prescribed bromocriptine for prolactinoma and responded to her symptoms. So what do you think is its mechanism of action? What do you think is the mechanism of action of bromocriptine? Yes. So if you take this bromocriptine, remember bromocriptine is not a partial agonist to your D2 receptor. Right? It is not a partial agonist. It is a D2 receptor complete agonist. Right? It is a D2 receptor complete agonist. And you know what the bromocriptine will do in case of the prolactinoma? In prolactinoma, it normalizes the serum prolactin level. It normalizes the serum prolactin level. That is what the bromocriptine does. It is not a D2 partial agonist. It's a D2 complete agonist. Okay? Right. Now, let us discuss about the prolactinoma. Right? Let us discuss about the prolactinoma. So, very simple question. Which of the following is the most common type of pituitary adenoma? Which of the following is the most common type of pituitary adenoma? So, you have two questions here. So, if the question is asked the most common tumor, the question is asked most common secretory tumor, right? The most common tumor will be non-secretory pituitary adenoma, right? Non-secretory pituitary adenoma. If the question is asked most common secretory adenoma, then the answer will be prolactinoma. Right? The answer will be prolactinoma. But it is not been asked here. We don't have the option of non-secretory adenoma. Then what would be the best answer here? The best answer will be prolactinoma. So please remember that's a very important question. Okay? Right. Now, the next important question you see here. A 35-year-old female presents with 1 year history of menstrual irregularity and galactorrhea. She also has on and off headache. On examination, they revealed bitemporal superior quadrantenopia. Fundus examination showed there is primary optic atrophy. Which of the following is the most likely diagnosis in this case? Craniopharyngioma, pituitary macroadenoma, your ophthalmic artery aneurysm, chiasmal glioma. Right. So, what is the answer in this? Excellent, my dear students. Right. So, the individual is having galactorrhea. Along with that, there will be bitemporal superior quadrantenopia. That means there is mass effect and even there is headache. When will you have a mass effect? You will have mass effect when there is macroadenoma, but not in case of microadenoma. Okay. Right. So, what is the difference between micro and macroadenoma? Microadenoma means the size of the tumor is less than 10 mm. Macroadenoma means the size of the tumor will be more than 10 mm. In microadenoma, you will have only endocrine manifestations. Whereas in macroadenoma, along with the endocrine manifestations, you also have mass effect on the surrounding structure. What is that mass effect on the surrounding structures? That will be compression of the optic chiasma resulting in bitemporal hemianopia. And what is the important differential diagnosis for prolactinoma? Can anyone answer this question? What is the important differential diagnosis for prolactinoma? Yes, any one of you please. Differential diagnosis for prolactinoma. The important differential diagnosis for prolactinoma will be craniopharyngioma, right? And what is the difference? Even your craniopharyngioma can also cause hyperprolactinemia, but the difference is the mass effect. Prolactinoma, it will cause bitemporal superior quadrantenopia, whereas craniopharyngioma, it will cause bitemporal inferior quadrantenopia. Right, it will cause bitemporal inferior quadrantenopia. That is what you will have in case of craniopharyngioma. And okay, so that is the difference. Bitemporal superior quadrantenopia, prolactinoma. Bitemporal inferior quadrantenopia, craniopharyngioma. Okay, right. The next important is investigation of choice for hyperprolactinemia. Any one of you? Investigation of choice for hyperprolactinemia. Anyone? Investigation of choice will be serum prolactin levels. Serum prolactin levels. Normal value कितना होगा? Normal value जो है, it is 5 to 20 nanograms per ml. That will be the normal value. But in prolactinoma, prolactin levels कितना होगा? Prolactinoma में levels जो है, it will be more than 200 nanograms per ml. ठीक है? First line treatment क्या होगा? What will be the first line treatment? Right? Whether it is microadenoma or macroadenoma, the first line treatment will be your dopamine agonist. Which dopamine agonist? Can anyone tell me which particular dopamine agonist is the drug of choice? Which particular dopamine agonist is the drug of choice? Any one of you? That will be your, right, that will be not bromocriptine. It is cabergoline. Right, it will be cabergoline. That will be the drug of choice. Okay? Next, then in pregnancy, right, in pregnancy, the drug of choice will be bromocriptine. Right, in pregnancy, the drug of choice will be bromocriptine. Okay, and in spite of giving this dopamine agonist, if the prolactin level does not decrease, or if the size of the tumor does not decrease, then you have to consider for surgery. Then you have to consider for surgery. Okay, right. So that was about your prolactinoma. Then coming to your hypopituitarism. So what is the hormone In hypopituitarism, what is hypopituitarism? It is like partial or complete loss of anterior pituitary function, right? Partial or complete loss of the anterior pituitary function. Now, what is the first question that will be asked? What is the hormone that is being reduced earliest? What is the hormone that is reduced earliest in hypopituitarism? Any one of you, please? The hormone that is reduced earliest. Anyone? Very good. That will be growth hormone. Growth hormone is the one which is reduced earliest. Then followed by that gonadotrophins. What are those gonadotrophins? That is follicle stimulating hormone and as well as the luteinizing hormone. These are the next important hormones that are being reduced. Now, what is the most common cause of hypopituitarism? What is the most common cause of hypopituitarism? That will be pituitary adenomas. Right? Pituitary adenomas, that will be the most common cause of the panhypopituitarism. Right? Now, whenever you are treating, right, you will treat the patients, you need to supplement all the hormones. But what is the most important hormone that has to be supplemented? Any one of you? What is the most important hormone that has to be supplemented? A quick question. Anyone? That will be cortisol. Cortisol is the first important hormone that has to be supplemented. Okay? So, three important questions. The hormone which is which is decreased first in hypopituitarism, growth hormone. Most common cause, pituitary adenoma. The first hormone that has to be replaced, corticosteroid. Okay? So we are done with the acromegaly. We are done with the prolactinoma. We are done with the hypopituitarism. And next important now is the disorders related to the antidiuretic hormone. Okay? Right. Now, what is this diabetes insipidus? Yes, until now, is everyone comfortable? Any problem until here? Yes. Is there any problem until here? I'm very happy that you people are very much interactive. You are answering very nicely in the chat box. Okay. Now, we'll move on to the next topic, that is diabetes insipidus. What is diabetes insipidus? Diabetes insipidus is that where there is deficiency of the antidiuretic hormone, right? Where there is deficiency of the antidiuretic hormone. Either it is deficiency or it is resistance to the action of the antidiuretic hormone. Diabetes insipidus में clinical features क्या होगा? The clinical feature is that they will have polyuria. When will you use the word polyuria? When there is abnormally large volumes of dilute urine. And how much should be that abnormally large volume of dilute urine? If you take per 24 hours, it should be more than 3 liters per 24 hours. Or if you take per kg body weight, so it should be more than 40 to 50 ml, right? 40 to 50 ml per kg in 24 hours. Right? 24-hour urine volume, it should exceed more than 40 to 50 ml per kg body weight. Okay? Right. So that is about your diabetes insipidus. And in case of diabetes insipidus, I'll just show you a question. Please answer this. Let me see how many of you can answer this. Choose the best lab value for a patient with central diabetes insipidus. Choose the best lab value for a patient with central diabetes insipidus. Yes? Right. So, diabetes insipidus patients में what should happen to the serum osmolality? Increase होना. फिर यूरिन ऑस्मोलैलिटी क्या होना है पेशेंट्स में? यूरिन ऑस्मोलैलिटी कम होना है, डिक्रीज होना है. सो व्हाट इज दैट आंसर? दैट विल बी 50/300. सो यूरिन ऑस्मोलैलिटी कम है और सीरम ऑस्मोलैलिटी ज्यादा है इन द फर्स्ट ऑप्शन, बिकॉज Normal serum osmolality is how much? 285 to 295 milliosmoles. And how much is the normal urine osmolality? Normal urine osmolality will be 300 to 1000 milliosmoles. That will be the normal urine osmolality. Okay? Right. Now, regarding the etiology, we have one important question in the uh, diabetes insipidus regarding the etiology. See, actually, you have etiology causing central diabetes insipidus and you have etiology causing nephrogenic diabetes insipidus. Okay, central diabetes insipidus means where there is decrease in antidiuretic hormone. Nephrogenic diabetes insipidus means where there is resistance to the action of antidiuretic hormone. Now, the question is the Wolfram syndrome. Can anyone tell me what is Wolfram syndrome? Wolfram syndrome will cause which type of diabetes insipidus? Wolfram syndrome is nothing but nephrogenic diabetes insipidus. Right? Nephrogenic diabetes insipidus. Okay? And it is also called as Did-mode syndrome. Right? And what type of inheritance is your Wolfram? Wolfram syndrome, it is mainly due to mutation of WFS1 gene mutation. Right? WFS1 gene mutation. And the type of inheritance is autosomal recessive type of inheritance. DI stands for diabetes insipidus. DM will be diabetes mellitus. OA stands for optic atrophy. And the last D stands for deafness. The last D stands for deafness. Please remember Wolfram syndrome. And you have many other causes. Okay. Can anyone tell me what are the drugs? What are the drugs that will cause nephrogenic diabetes insipidus? Any one of you, please? The drugs causing nephrogenic diabetes insipidus will be lithium, cisplatin. Then what are the other drugs? Amphotericin B. Right? Then next, aminoglycosides. These are all the drugs. And next, methoxyflurane, which is an inhalational anesthetic drug. Right? These are all the drugs which are responsible for your nephrogenic diabetes insipidus. Okay? Right, very good. Now, what is the investigation of choice? Already investigations तो मैं बोल दिया. What is that? Serum osmolality बढ़ जाएगा और urine osmolality कम हो जाएगा. Urine osmolality will be reduced. And what will happen to serum sodium? Serum sodium also will be elevated. Then what will be the investigation of choice? That is the question. Any one of you, investigation of choice क्या होगा? Very good. The investigation of choice will be water deprivation test. Right? That will be the investigation of choice. Okay? Then followed by that, you see this question. A 33-year-old lady presents with polyuria, polydipsia. Her symptoms started soon after a road traffic accident 6 months ago. The blood pressure is 120 by 80, no postural drop. Daily urine output is 6 to 8 liters. Sodium 130, potassium 3.5, urea 15, sugar 65, plasma osmolality 268, urine osmolality 45. What is the most likely diagnosis? Right. No. It is not central diabetes insipidus. What is the diagnosis? The answer is psychogenic polydipsia. The answer is psychogenic polydipsia. Why? Because if you take the question, plasma osmolality 268, that means decreased. Urine osmolality 45, that means decreased. Diabetes insipidus में क्या होगा? Diabetes insipidus में plasma osmolality बढ़ जाएगा, increases. But here it is decreased. Where will you have this? You will have this in case of sorry, you will have this in case of psychogenic polydipsia. Psychogenic polydipsia में दोनों कम रहता है. ठीक है? Next, which of the following is the drug of choice for central diabetes insipidus? What will be the drug of choice for central diabetes insipidus? The drug of choice for central diabetes insipidus will be desmopressin. Right? A vasopressin analog. What we give? Desmopressin. And this desmopressin, it can be given through inhalational route, can be given subcutaneous route. can be given intravenously. These are all the various routes by which you can give desmopressin. Okay. Then, what is the drug of choice for nephrogenic diabetes insipidus? Drug of choice for nephrogenic diabetes insipidus. Any one of you? Drug of choice for nephrogenic diabetes insipidus will be thiazides, that is hydrochlorothiazide, right? Then what is the drug of choice for lithium induced diabetes insipidus? Drug of choice for lithium induced diabetes insipidus. Any one of you, please? Amiloride. Excellent. Amiloride will be the drug of choice for nephrogenic diabetes, lithium induced diabetes insipidus. Okay, so that is about your diabetes insipidus. The next important topic is SAADH. SAADH kya hoga? It is the condition where there is excessive increase in your antidiuretic hormone. Okay, right. Now, SAADH is associated with which type of bronchogenic carcinoma? Bronchogenic carcinoma is one of the etiology which will cause SAADH. But which type of bronchogenic carcinoma? Very good. It is your small cell carcinoma of the lung, which is also called as Oat cell carcinoma, right? Which is also called as Oat cell carcinoma. And all the symptoms in SAADH are due to what? These patients with SAADH, they develop hyponatremia. So hyponatremia के वजह से SAADH में symptoms आएगा. What will be that? Yeah, answer this. All are true regarding SAADH except increased levels of antidiuretic hormone, urine will be hypoosmolar, hyponatremia, adequate hydration status, which is the incorrect statement. Yes, quickly. Incorrect statement. Very good. So, SAADH patients may urine will not be hypoosmolar, urine will be hyperosmolar, right? Why is that? Because the urinary sodium levels are elevated. That is the reason why urine will be hyperosmolar. So, all the clinical features in SAADH are due to what? That is due to hyponatremia. What will be that? Hyponatremia के वजह से patient will be in altered sensorium. Patient will be in a they present to you with seizures, right? The patient may land up in coma and finally die. So all the clinical features in patients with SAADH is due to hyponatremia. Then SAADH patients में investigations क्या होगा? Very very important. Please mark this slide as an important, which I am about to teach you now. So first and foremost, the serum osmolality क्या होगा? कम हो जाएगा. Next, urine osmolality. What will happen? Increases. Serum sodium. What will happen to serum sodium? Decreases. What will happen to the urinary sodium? Increases. Okay. Then what will happen to blood urea nitrogen and as well as serum creatinine? That will be reduced. Okay. Then what will be the investigation of choice? Investigation of choice will be water loading test. What is the investigation there in diabetes insipidus? Water deprivation test, but whereas here it is water loading test. Okay, so that is about your the investigations in patients with the SAADH. Okay, right. The serum being hypoosmolar, that means how much will be the osmolality? Less than 285. Less than 285. Okay, right. Then you see the next question. SAADH, all are true except SAADH, all are true except, which is the incorrect statement. So, in patients with SAADH, if you take the urinary sodium will not be normal. What will happen to the urinary sodium? Urinary sodium is increased. And hyponatremia, yes, it will be there. And what is the drug of choice? Drug of choice will be vaptans. Which particular vaptans we give? We give tolvaptan, and this tolvaptan, it is given through oral route. And other vaptan is conivaptan, right? So how do we give this conivaptan? This conivaptan is given through the intravenous route. So the drug of choice will be vaptans, that is vasopressin receptor antagonists, right? They will antagonize the B2 receptors which are present at the level of your collecting duct, and thereby they are being used as a drug of choice. Actually, previously we were using demiclocycline, but this demiclocycline, it was causing nephrotoxicity. So demiclocycline was taken off. Now the new drugs are the vaptans. So this finishes your pituitary disorders. So what all we have finished now? Acromegaly, hypopituitarism, prolactinoma, diabetes insipidus, SIADH. 5 topics we are done. Then next we'll move on to adrenal gland disorders. So in the adrenal gland disorders, by seeing the image itself, you can diagnose. What is this image suggestive of? Lady with central obesity and abdomen skin showing the purple striae. That is what is nothing but your Cushing syndrome, right? Cushing syndrome. Now you should know this important group of questions. You should know this important group of questions. That is the most common cause, right? Most common cause of Cushing's. What will be that most common cause of Cushing's? That will be iatrogenic steroid supplementation. Most common cause of non-iatrogenic Cushing's, that will be pituitary adenoma. What type of pituitary adenoma? That is corticotroph type of pituitary adenoma, which will be producing excess amount of ACTH. Then most common cause of ACTH dependent type of Cushing's, that is also the pituitary adenoma. What type of pituitary adenoma? Again the same thing, corticotroph type of pituitary adenoma. Most common cause of ectopic ACTH causing Cushing's, that will be small cell carcinoma of the lung, which is nothing but the oat cell carcinoma. And finally, what is the most common cause of ACTH independent type of Cushing's? That will be adrenal adenoma, right? That will be adrenal adenoma. So these 5 questions related to the etiology are very important. Now, clinical features. Earliest manifestation of the Cushing's. Anyone? Earliest manifestation of the Cushing's will be weight gain, right? And because of this weight gain, the individual will develop insulin resistance and will also develop diabetes mellitus. Okay? Then next important is the skin manifestation. In Cushing syndrome, you will have this purple striae over the abdomen. There will be also easy bruisability, and there will be also hyperpigmented skin. But this hyperpigmented skin, you will have that only in case of ACTH dependent type of Cushing's, not in case of ACTH independent type of Cushing. Okay, next. Then, which of the following features is not seen in Cushing syndrome? Anyone? Which of the following features is not seen in patients with the Cushing syndrome? That will be hypoglycemia. So hypoglycemia will not be there. In Cushing's, what will you have, my dear students? That will be hyperglycemia, that will be there, but not hypoglycemia. Remaining all, hypertension can be there, frank psychosis can be there, and even hypokalemia can be there. Next, coming to the investigations in Cushing's. Yes, tell me now, what is the first line investigation in the Cushing's? What is the first line investigations in Cushing's? That is, you need to check for 24-hour urinary cortisol levels. So 24-hour urinary cortisol levels, they are elevated, right? 24-hour urinary cortisol levels are elevated. That will be the first line investigation in the Cushing. Then what is the earliest biochemical change in Cushing's? What is the earliest biochemical change in Cushing's? The earliest biochemical change in Cushing's will be loss of diurnal variation. Right? Loss of diurnal variation. That will be the earliest biochemical change. Right? What is that? Early in the morning, cortisol levels are high. Late in the evening, cortisol levels are very high. That is the earliest biochemical change. In a normal individual, early in the morning high, late in the evening low. But biochemical change will be loss of diurnal variation. Okay? Then one important clinical scenario is a 50-year-old male presents with history of hemoptysis. He is having truncal obesity and hypertension. Had an elevated ACTH level not suppressible with high dose dexamethasone. What would be the most probable diagnosis? What would be the most probable diagnosis? Any one of you? Right, very good. So, there are 2 points here. He is a chronic smoker that can predispose to the development of small cell carcinoma of the lung. Next, not suppressible with high dose of dexamethasone. You will have that in case of ectopic ACTH. Okay. Whereas with high dose of dexamethasone, if it is pituitary ACTH, the pituitary ACTH will decrease with high dose of dexamethasone, but not the ectopic ACTH. Okay. Then you should know the treatment. Yeah. Patient having Cushing syndrome due to adrenal tumor. What is the drug to be given? What is the drug to be given? Actually, what is the treatment of choice? The treatment of choice will be surgical resection. But if the patient does not, or if the patient is not willing for surgery, the drug of choice will be ketoconazole. Ketoconazole का mechanism of action क्या है? Ketoconazole का mechanism of action जो है, it is an adrenal enzyme inhibitor. And what is the friend of ketoconazole? The friend of ketoconazole is etomidate. The friend of ketoconazole is etomidate. Okay. Even your etomidate, it is also an adrenal enzyme inhibitor. Right? It is also an adrenal enzyme inhibitor. And adrenolytic agents are metotane. And drugs that will target the pituitary will be cabergoline. And when you do a bilateral adrenalectomy, you have to give replacement glucocorticoids. And that replacement glucocorticoids is by hydrocortisone. Now, one important question is Nelson syndrome. Can anyone tell me what is Nelson syndrome? What is Nelson syndrome? What is Nelson syndrome is, Nelson syndrome is the condition where when you do a bilateral adrenalectomy, right, when you do a bilateral adrenalectomy, what will happen to the ACTH levels? So the steroid levels will be reduced. When steroid levels are reduced, ACTH levels will be increased. When ACTH is increased, parallelly MSH is also increased. When MSH is increased, what will happen to the pigmentation? There will be hyperpigmented skin. And this hyperpigmented skin secondary to bilateral adrenalectomy, that is what is called as the Nelson syndrome. Okay, so this is about your Cushing's. Next important adrenal gland disorder will be the Conn syndrome. Next is Conn syndrome. Now, let me show you a question. You see this. Testing for primary aldosteronism should be done for all of the hypertensive patients except testing for primary hyperaldosteronism should be done for all the hypertensive patients except any one of you? Right. So, primary hyperaldosteronism is one of the cause for hypertension. So sustained hypertension can be there, resistant hypertension can be there, right? And requirement of 4 or more antihypertensives can be there. But in hyperaldosteronism, hyperkalemia will not be there. Aldosterone will cause potassium excretion. So there will be hypokalemia but not hyperkalemia. Right? Hypokalemia ho sakta but not hyperkalemia. Okay? Then what is the answer is D, fourth option. Then most common cause of Conn syndrome is yes, quick answer. Most common cause of the Conn syndrome is adrenal adenoma. Most common cause of primary hyperaldosteronism, that will be bilateral adrenal hyperplasia. Right? Bilateral adrenal hyperplasia. That will be the most common cause of primary hyperaldosteronism. So, most common cause of Conn syndrome is what? Adrenal adenoma. We use the word Conn's only for adenoma. We don't use that for bilateral adrenal hyperplasia. Okay? Then, what will be the clinical features? In primary aldosterone का physiological action क्या है? It will increase the sodium and water retention. It will decrease the potassium levels. It will decrease the H plus ion levels. So because of increase in sodium and water retention, there will be diastolic hypertension. And remember, they will have polyuria because of aldosterone escape phenomenon, and there is no edema. And even there is no edema is because of aldosterone escape phenomenon and hypokalemia. This hypokalemia will cause very severe muscle weakness. Right? Will cause very severe muscle weakness. And there can be also development of arrhythmias. Right? There can be also development of arrhythmias. And there is increased H plus ion excretion, and that will result in metabolic alkalosis. That will result in metabolic alkalosis. So we have two forms of hyperaldosteronism. One is primary hyperaldosteronism, the other one is secondary hyperaldosteronism. Primary hyperaldosteronism is the problem is within the gland. Secondary hyperaldosteronism, what are the etiologies? Congestive heart failure or cirrhosis of liver. And how will you differentiate both of them? That is based on the renin levels. Renin levels in primary, that will be reduced. Renin levels in secondary will be increased. So based on renin levels, we can differentiate primary and as well as secondary. Then coming to the investigations. So what is the important screening test for your primary hyperaldosteronism? The important screening test will be aldosterone renin ratio. Right? Aldosterone renin ratio. That will be increased in case of the primary hyperaldosteronism. That is a screening test. Then what is the confirmatory test for your primary hyperaldosteronism? The confirmatory test for primary hyperaldosteronism is oral salt solution test. Right? Oral salt solution test. And if the individual cannot consume the oral salt solution, then you need to do IV saline suppression test. Okay, IV saline suppression test. Okay, so this will be the confirmatory test for your primary hyperaldosteronism, right? Then how do you treat? What is the treatment of choice for primary hyperaldosteronism? The treatment of choice is surgical resection of the tumor. Right? Surgical resection of the tumor. But if there is bilateral adrenal hyperplasia, if there is bilateral adrenal hyperplasia, we don't do surgical resection. In case of bilateral adrenal hyperplasia, the drug of choice will be aldosterone antagonist. And what will be that aldosterone antagonist? That will be spironolactone, right? And with spironolactone, what is the important adverse effect with spironolactone? What is the important adverse effect with spironolactone? That will be a tender gynecomastia. So, whenever the individual develops a tender gynecomastia, then in such case, what do we give? We give eplerenone, right? We give eplerenone, okay? And you should know the drugs causing gynecomastia. What are all the various drugs that will cause gynecomastia? I think you are aware of this particular mnemonic. Okay, I hope you are all aware of this mnemonic. What is this? D stands for digoxin. What does this I stands for? Isoniazid. S stands for spironolactone. T stands for cimetidine. K stands for ketoconazole. O stands for estrogen supplementation. S stands for stilbestrol. Right? S stands for stilbestrol. So these are all the drugs which will cause the gynecomastia. Right? Now, one last question on the topic of hyperaldosteronism. Right. Prior to testing for hyperaldosteronism, patient should ideally hold all the medications except, that means which among the following medications need not be stopped before testing for hyperaldosteronism? Any one of you? So that will be, no, you have to stop diuretics. Aldosterone antagonists, you have to stop. Otherwise, you will get the false negative value. ACE inhibitors, you have to stop. Otherwise, you get the false negative value because it will suppress your aldosterone formation. NSAIDs, what they will do? They will decrease the renal perfusion. There will be activation of RAS. So there will be increase in aldosterone production. But verapamil does not affect the aldosterone synthesis. So the answer is verapamil. So holding the verapamil is not required. Okay? So that is about your Conn syndrome. Then the next important adrenal gland disorder will be the Addison's. Right? Now, Addison's, what is this? It is adrenocortical insufficiency. So, right, you have primary and secondary adrenocortical insufficiency. Primary means where is the problem? The problem is within the adrenal gland itself. Whereas secondary means the problem is in the pituitary gland. So thereby what will happen to ACTH levels in secondary? Reduced. What will happen to the ACTH levels in primary? Increases because of your inhibition of feedback mechanism, or by feedback mechanism the ACTH levels will be reduced in primary. In primary, which all hormones will be reduced? Steroids reduced. Aldosterone reduced. Weak sex hormones, that is also being reduced. Whereas in secondary, which all hormones will be reduced? Steroids, that will be reduced. Aldosterone, that will remain normal. Weak sex hormones, that will be reduced. Right? Weak sex hormones, that will be reduced. So the difference is what? The difference is your aldosterone. The difference is your ACTH levels. That is what is the difference between your primary and as well as secondary adrenocortical insufficiency. Right? Next, what is the most common cause of adrenal insufficiency in India? Most common cause of adrenal insufficiency in India, that will be tuberculosis. Whereas the most common cause of adrenocortical insufficiency in the West, that will be autoimmune adrenalitis. Right? That will be autoimmune adrenalitis. That will be the most common cause of adrenocortical insufficiency in the West. Then, what are the fungal infections that will cause Addison's? Fungal infections that will cause Addison's will be histoplasmosis. Then, what are the viral infections that will cause Addison's? Viral infections that will cause Addison's will be cytomegalovirus, right? Then, what is adrenomyeloleukodystrophy? Adrenomyeloleukodystrophy, it is an X-linked disorder. This is more commonly seen in males rather than females. There will be adrenal insufficiency. There will be also neurological manifestations in adrenomyeloleukodystrophy, and there is also accumulation of fats, right? There is also accumulation of fats. That is what is your adrenomyeloleukodystrophy. Next, what are the infiltrative disorders that will cause Addison's? The infiltrative disorders that will be causing Addison's will be hemochromatosis, where there is excessive iron accumulation. Then sarcoidosis, where there is accumulation of non-caseating granuloma. Sarcoidosis, right? Then these are the infiltrative disorders that will be causing Addison's. Then what are the malignancies that will be causing Addison's? That will be metastasis to the adrenal gland, and even lymphoma that can also cause the Addison's. So these are the malignancies that will cause the Addison's. Then what will be the secondary adrenocortical insufficiency? Secondary means the problem is not within the adrenal gland, the problem is in the pituitary. So that will be the hypopituitarism, right? Any trauma to the pituitary, okay? Any hypoperfusion to the pituitary, pituitary adenoma, all these can cause adrenocortical, secondary adrenocortical insufficiency. Then what will be the clinical features? See, because of glucocorticoid deficiency, there will be hypoglycemia, and they can also have hypotension. Because of mineralocorticoid deficiency, there will be hyponatremia, right? And the individual will have hyperkalemia, and the individual will have metabolic acidosis. And adrenal androgen deficiency, there will be loss of secondary sexual characteristic features, that is loss of axillary hair and pubic hair. Then other features will be pigmentation. So if you see the pigmentation, in primary you will have hyperpigmented skin. In secondary you will have hypopigmented skin, and that hypopigmented skin is what is nothing but alabaster skin, right? Now I'll show you one of the important, okay, and where will you have this hyperpigmentation in primary? That is over the palm and sole creases, right? And you will also have this hyperpigmentation. So this will be the first place where you have the hyperpigmented skin in Addison's disease, and then followed by that you also have pigmentation which is being distributed around the areola and as well as the axilla, then even within the groin, then even within the oral mucosa. So these are all the places where you have the hyperpigmented skin. Now I'll show you one important personality. Please identify this person. Please identify this person and tell me, like, what does he have? So he is nothing but a very great personality, John F. Kennedy. John F. Kennedy was the person who had this Addison's, right? Who had this Addison's and hypopigmented skin. Where will you have hypopigmented skin? That is in secondary adrenocortical insufficiency, right? Next, very important is Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome is adrenal crisis where there will be hypotension and death, and organism will be Neisseria meningitidis. That is meningococcal infection, mainly in case of children, right? And what is the drug of choice? Drug of choice will be hydrocortisone. And what will be the antibiotic that you should be giving? That will be ceftriaxone. So Waterhouse-Friderichsen syndrome is that which is seen in children or newborn secondary to meningococcal infection causing adrenal crisis or adrenal hemorrhage. Then you should know the most diagnostic test. What is the investigation of choice? What is the investigation of choice? Investigation of choice will be right. That will be ACTH stimulation test, which is also called co-syntopin test. Right, which is also called co-syntopin test. Right. Then what will be the CT scan showing? CT scan shows the moth-eaten adrenal gland. That will be the CT picture. Then coming to the treatment. So what will be the drug of choice in primary? Drug of choice in primary adrenocortical insufficiency will be oral hydrocortisone, because in primary steroids, aldosterone and weak sex hormones, everything is reduced, and we need to give a steroid which has the dual activity, steroid activity and aldosterone activity, that is there in case of the hydrocortisone. Then what is the drug of choice in secondary and tertiary adrenocortical insufficiency? You should give a potent steroid, and that particular potent steroid will be dexamethasone. That potent steroid will be dexamethasone. So that completes your Addison's adrenocortical insufficiency. Then next important topic is, the next important adrenal disorder will be pheochromocytoma. Right, pheochromocytoma. Now what is this pheochromocytoma? Pheochromocytoma, it's a tumor of the adrenal medulla. Right, it's a tumor of adrenal medulla. And where will this pheochromocytoma originates from? It originates from neuroendocrine cells of the adrenal medulla, which are also called chromaffin cells. And this pheochromocytoma, predominantly it secretes norepinephrine. And this pheochromocytomas, they not only originate from the adrenal medulla, the pheochromocytomas, they also originate from the extra-adrenal site. Now this extra-adrenal site pheochromocytomas, they are called paraganglioma, or this is also called chemodectoma. Right, paraganglioma or chemodectoma. Can anyone answer this question? Very good. That is, organ of Zucker-Candle is the most common extra-adrenal site of pheochromocytoma. And even these paragangliomas, they also produce norepinephrine in excess quantity. And coming to the clinical features, all are the clinical features of pheochromocytoma except, any one of you? Except. So, in pheochromocytoma, you will have increased hematocrit. There will be orthostatic hypotension because of blunting of the sympathetic reflexes. But low cortisol level is not the feature of pheochromocytoma. It is a feature of Addison's. And there will be impaired glucose tolerance, or there will be increase in the glucose levels in patients with the pheochromocytoma. Okay? Right. And you should know, in pheochromocytoma, what is the most common symptom? The most common symptom in patients with pheochromocytoma will be headache. Why is this headache? That is because of hypertension. Okay. Then what is the most common sign? The most common sign will be hypertension. And these patients, they are also prone for arrhythmias because of excessive catecholamines. Then what is the investigation of choice for screening? The investigation of choice for screening will be 24-hour urinary fractionated metanephrines. 24-hour urinary fractionated metanephrines. That will be elevated. Then what is the confirmatory test? The confirmatory test for your pheochromocytoma will be plasma catecholamine levels or plasma metanephrine levels. And how many times it has to be elevated? It has to be elevated almost 4 times. right? They have to be elevated almost 4 times. Then for localization of the tumor, right? For localization of the tumor, what is the investigations you have to do? That is gallium 68 dotatate scan, right? Gallium 68 dotatate scan is for localization of the tumor. That is the most sensitive investigation for localization of the tumor. Okay, next, then your VMA. VMA stands for what? Vanillyl malic acid. Vanillyl malic acid is elevated in which of the following conditions? Primary micronodular adrenal hyperplasia, Conn syndrome, neuroblastoma, tuberous sclerosis. In which of the following condition the VMA levels are elevated? Any one of you? No. It is not MRI or it is not your MIBG scan. For localization of the tumor, the most sensitive will be gallium dotatate scan. No. So we have one student. Abhay has answered this question correctly. Very good, Abhay. So that will be neuroblastoma. Neuroblastoma is also the one which will produce excess amount of vanillyl malic acid levels. So I'll give you all the conditions where VMA levels are elevated. In all these conditions, the VMA levels are elevated. Right? It is not only pheochromocytoma, it is also increased in neuroblastoma, also increased in ganglioblastoma, ganglioneuroma, and even severe anxiety. Then finally, what is the treatment of choice for pheochromocytoma? Treatment of choice for pheochromocytoma is surgical resection of the tumor. But you know one important point, before doing surgical resection, you have to maintain the blood pressure less than 160 by 80. So how will you achieve this? Right? How will you achieve this? You will achieve this by giving an alpha blocker, that is phenoxybenzamine. Right? You have to give phenoxybenzamine for achieving this blood pressure. Right? So that is about your pheochromocyte. Right? Next. Now, so we are done with the adrenal gland disorders. Right? Cushing's, Conn's, Addison's, and then pheochromocytoma. Right? So how is everything going on until here? So is everyone comfortable with the class which is going on, or is there any problem? Yes, some quick response in the chat box. Okay, very good. Yeah, Shashi, I will discuss even men's syndromes also. Right, now let us discuss parathyroid disorders. So parathyroid disorders, thyroid disorders, diabetes mellitus, men's syndrome, carcinoid syndrome, and then glucagonoma. These are the remaining topics. Okay? Right, now, yes, the commonest cause of primary hyperparathyroidism is, commonest cause of the primary hyperparathyroidism is, so the commonest cause of primary hyperparathyroidism will be solitary adenoma of parathyroid. Right? The commonest cause will be solitary adenoma of parathyroid. That is the commonest cause. Then you have many other causes. Multiple adenoma is there, a parathyroid hyperplasia is there, and parathyroid carcinoma is also there. But the most common cause will be solitary adenoma. Then we also have secondary hyperparathyroidism. Secondary hyperparathyroidism is what? Secondary hyperparathyroidism is that where there is a hypocalcemia causing increase in parathormone production. Where can you have that? Chronic renal failure, vitamin D deficiency, malabsorption syndrome, medullary carcinoma of thyroid. Then we have ectopic sources of parathormone causing hyperparathyroidism. What are those ectopic sources? That will be squamous cell carcinoma of the lung, adenocarcinoma of the kidney. Now, in case of hyperparathyroidism, what all will be the clinical features? So, whenever parathormone levels are elevated, what the parathormone will cause bone resorption. So once there is bone resorption, excessive bone resorption will be there. Once there is excessive bone resorption, the cells of healing will go there and will try to heal the bone. And what are the cells of healing? Fibroblasts. So within the bone, you will have osteitis fibrosa cystica, right? Next, and because of increased bone resorption, you have abnormalities within the spine, and that particular spine we use that you will have in patients with hyperparathyroidism will be codfish spine, right, where there is excessive scalloping, right? Next, the another important abnormality within the spine will be Rugger Jersey spine, right? What is this spine called? Rugger Jersey spine. So why do you get this Rugger Jersey spine? So you can see this alternate, you can see this alternate white and black, white and black, white and black. So this alternate white and black, it is giving you the appearance of a Rugger Jersey. So that is the reason why it is called a Rugger Jersey spine. Okay, and you are getting this alternate white and black because of excessive bone resorption by increased parathormone. By increased parathormone. Then what is the appearance within the skull? Because of excessive resorption within the skull also, you will have this classical pinhead stippling, right? So yeah, you can see this pinhead stippling or the raindrop appearance. And within the dental film, so you have a structure called lamina dura. What is this lamina dura? Lamina dura is nothing but the mineralization of the mandible, right? Lamina dura is nothing but the mineralization of the mandible, and in case of hyperparathyroidism there will be demineralization of the mandible, right? Whenever you take a dental film, the dental film you can see here, this is the normal lamina dura, right? This label A is your lamina dura. Then what will happen in patients with hyperparathyroidism? There will be loss of lamina dura or there will be absence of the lamina dura. And why is that? That is because of the demineralization of the mandible by your hyperparathyroidism. And in patients with hyperparathyroidism, you also have an important tumor, and this particular tumor will be Epulis tumor. This particular tumor will be Epulis tumor. Okay, then how will you diagnose your hyperparathyroidism? That is mainly by localization of the tumor. So how is that you will do the localization of the tumor? The localization of the tumor can be done by a scan called technetium 99M custom EB scan, right? Technetium 99M custom EB scan, that will be the localization of the tumor. Then what is the treatment of choice? The treatment of choice will be surgical resection of solitary parathyroid adenoma. That will be the treatment of choice. Okay, then coming to the medical management. See, medical management, what is very important is the patient will have hypercalcemia because of excessive bone resorption. So what will be the first line management for your hypercalcemia? You need to give normal saline and you should create a dilution effect. You should create a dilution effect. Then the other important drugs will be the furosemide, and this particular furosemide will cause the loss of calcium. Even the furosemide will also decrease the calcium. And what will be the drug of choice to reduce the osteoporosis? Because there is bone resorption, you want to reduce that bone resorption, you can give ibandronate. Ibandronate is what? Ibandronate, it is a bisphosphonate, right? It is a bisphosphonate. And then calcitonin nasal spray, right? Calcitonin nasal spray. So that is about the treatment for your hyperparathyroidism. Coming to the next important topic, that is hypoparathyroidism. So if you take hypoparathyroidism, what will be the etiology that will cause hypoparathyroidism? That is mainly the thyroid surgery, which will cause acute hypoparathyroidism. But we have one important genetic disorder causing hypoparathyroidism. What is that important genetic disorder that we cause hypoparathyroidism? That is called Digeot syndrome. So how to remember the components of Digeot syndrome? The components of Digeot syndrome, if you see, the mnemonic that you have is catch-22. What is this catch-22? C stands for cardiac abnormalities. A stands for abnormal feces. T stands for thymic absence or thymic hypoplasia. C stands for cleft palate. H stands for hypocalcemia. Catch 22. That means the chromosomal abnormality is on 22. Now, what are the important points in your hypoparathyroidism? Important points in hypoparathyroidism is that in hypocalcemia, that is in latent tetany, you have this Troche's sign. What is that? You apply the BP cuff and you increase the systolic blood pressure, right? Increase the systolic blood pressure more than normal and wait for 1 to 2 minutes. Then you will observe this carpopedal spasm. That is what is nothing but a positive Troche's sign. And the next important sign is the Chostek sign. Now, what is this particular Chostek sign? Chostek sign is that you need to tap the facial nerve which is there at the angle of mandible. Right? When you tap the facial nerve over the angle of mandible, there will be spasm of the muscles on that half of the face. And that is what is called Chostek sign. These two you will have in case of the latent tetany. Very, very important signs. Okay. Next. Now, this particular Troche's, you have three important Troche's in the medicine. This is your Troche's lymph node. Where do you get Troche's lymph node? That is in carcinoma stomach, where the carcinoma stomach will metastasize to the left supraclavicular lymph node, which is also called Virchow's lymph node. That is what is called Troche's sign. The next important is the Troche's syndrome. Where will you have this Troche's syndrome? You will have that in patients with carcinoma of the pancreas. Right, you will have that in case of carcinoma of the pancreas, where you have migratory thrombophlebitis. So three important Troche's, please remember. Troche's sign in hypocalcemia. Troche's lymph node, carcinoma stomach. Right, Troche's lymph node, carcinoma stomach. Troche's syndrome, migratory thrombophlebitis, which is seen in carcinoma of the pancreas. Okay? Next, then next important is in patients with hypocalcemia, you will have abnormality within the bone, where there can be development of genu valgum, which is nothing but your knock knees, or genu varum, right, which is nothing but development of the bolex. Development of the bolex. Okay, genu varum. Okay, now how do you treat these patients with hypoparathyroidism? Very simple. Calcium deficiency is there, so calcium supplementation has to be done. Calcium supplementation has to be done. Okay, right. We have one more important form of hypoparathyroidism called as pseudo hypoparathyroidism. In pseudo hypoparathyroidism, parathormone is present at adequate quantities. Then what is the problem then? The problem is parathormone receptors are resistant. Right? Parathormone receptors are resistant. So because of that, the individual will suffer from hypocalcemia. So what is the treatment? Calcium supplementation. Right? Calcium supplementation. Why is this parathormone receptors being resistant? That is due to gene mutation. What is the gene which is being defective? The gene that is being defective is GNAS gene. Right? The gene which is being defective is GNAS gene. Now, in pseudo hypoparathyroidism, we have various subtypes. Type 1, 2, 3. We have pseudo hypoparathyroidism type 1A. In pseudo hypoparathyroidism type 1A, there is a syndrome called Albright hereditary osteodystrophy. Albright hereditary osteodystrophy. So, In Albright hereditary osteodystrophy, you have a classical sign. What is this classical sign in pseudohypoparathyroidism type 1A? In these patients with pseudohypoparathyroidism, right, pseudohypoparathyroidism type 1A, you have a short fourth and fifth metacarpal bones, and that will give you, whenever the individual makes a fist, you will have a knuckle dimple sign, right? Knuckle dimple sign. So this knuckle dimple sign, you have many differential diagnoses. What is that? Number one, Down syndrome. In Down syndrome, you will have short third metacarpal bone, so that is the reason why you get dimple knuckle sign. Whereas in Turner syndrome, fourth metacarpal is short, so that is the reason why in Turner syndrome you will get dimple knuckle sign. Okay, so differential diagnosis for your short third and fourth metacarpal will be Downs and as well as Turner's. Okay, so this is about your parathyroid disorders, that is hyperparathyroidism and as well as the hypoparathyroidism and as well as pseudo hypoparathyroid. Okay, right. So we are done with the parathyroid disorders. Then we'll move on to the thyroid disorders. So what is the most common cause of hypothyroidism in India? Any one of you? Most common cause of hypothyroidism in India. Most common cause of hypothyroidism in India will be Hashimoto's. Then, most common cause of hypothyroidism globally. What is the most common cause of hypothyroidism globally? That will be iodine deficiency. Iodine deficiency is the most common cause of hypothyroidism globally, right? Next, coming to the Hashimoto's. So what type of disorder is your Hashimoto's? Hashimoto's, it is an autoimmune disorder, right? It is an autoimmune disorder. And what are the type of cells which will infiltrate into the thyroid gland? Because it's an autoimmune disorder, so it is the lymphocytes which will infiltrate into the gland, right? What are Hurdle cells? Now what these antibodies will do? Antibodies will destroy the follicular cells, but some surviving follicular cells, right? But some surviving follicular cells. These surviving follicular cells, they are filled with pink colloid and they are called as the Hurdle cells. They are filled with pink colloid. They are called as the Hurdle cells. Now you should know what are the antibodies. The antibodies are basically IgG antibodies. And what is the name of those antibodies? These antibodies, we have four important antibodies. Number one, anti-thyroglobulin antibody, then antimicrosomal antibody, then antibody which is directed against the TSH receptor, then you have antibody which is being directed against the colloid. So these antibodies, what they will do? These antibodies, they destroy the follicular cells, and some surviving follicular cells will be there which are filled with pink colloid, that is called the Hurdle cells. Okay? Then next question is, there are certain drugs which will cause hypothyroidism. Can anyone tell me what are the drugs that will cause hypothyroidism? The drugs causing hypothyroidism will be amiodarone. Right? The drugs causing hypothyroidism will be the amiodarone. Okay? And many other drugs are there. Lithium, right? Para-amino salicylic acid. Then we also have an anti-neoplastic drug, that is sunitinib. Sunitinib is the drug which is used in the treatment of renal cell carcinoma. So these are all the drugs, right? These are all the drugs which will cause the hypothyroid. Then what is the most common cause of hyperthyroidism? What is the most common cause of hyperthyroidism? Any one of you? Most common cause of hyperthyroidism, that will be Graves. Right, that will be Graves disease. And what are the antibodies in the Graves? The antibodies in the Graves will be thyroid stimulating immunoglobulins. Right, thyroid stimulating immunoglobulins. Then what are the drugs that will cause hyperthyroidism? What are the drugs that will cause hyperthyroidism? That will be amiodarone. So amiodarone, it can cause both. It can cause hyperthyroidism and it can also cause hypothyroidism as well. Okay. Yes. Yes, Shashibhushan. Amyloidosis will cause hypothyroidism. And amyloidosis is what? Amyloidosis is an infiltrative disorder that will accumulate in the follicular cells and that can cause the hypothyroidism. Okay. Next, we have an important form of thyroid disorder that is called de Quervain's thyroiditis. What is de Quervain's thyroiditis? De Quervain's thyroiditis, it is secondary to viral infections. Right, it is secondary to viral infection, and you have a tender or painful thyroid, and it is also called granulomatous thyroiditis, or it is also called as giant cell thyroiditis. Right, granulomatous thyroiditis, it is also called giant cell thyroid, and it is secondary to infection. So even fever can be there in individuals with the de Quervain's thyroiditis. Okay, then in early stages of de Quervain's, what will happen to your radioactive iodine uptake studies in de Quervain's? The radioactive iodine uptake studies will be decreased. Then in early stages, there will be hyperthyroidism, and in later stages, the individual with de Quervain's will have hypothyroidism. Okay, and when you do a biopsy in patients with de Quervain's, the biopsy will show you the presence of the giant cell, and that is the reason why it is called giant cell thyroid, or it is also called granulomatous thyroid. Okay, so that is about de Quervain's. And radioactive iodine uptake studies are very, very important, which are being reduced. Okay, next is the two important points you need to know: Jod-based dose and Wolff-Chaikoff. Yes, please answer this. The occurrence of hyperthyroidism following administration of supplemental iodine to subjects with endemic iodine deficiency goiter is known as. Just 1 minute, guys. 1 minute. I'll just correct the screen. Right. So the occurrence of hyperthyroidism following administration of supplemental iodine. Yes, very good. So Jod-based dose is your hyperthyroidism. So you see this now. A patient with endemic iodine deficiency goiter, and you have supplemented iodine. So there can be two things that the individual can develop. There can be development of hypothyroidism, there can be development of hyperthyroidism. If there is development of hypothyroidism after supplementing the iodine, what do we call this as? That we call it as the Wolff-Chaikoff effect. Whereas after supplementing iodine, if there is development of hyperthyroidism, that we call it as Jod-Bezos phenomenon. Right? That we call it as Jod-Bezos effect. Okay. And this Wolff-Chaikoff effect, it is mainly due to inhibition of organification. Right? It is mainly due to inhibition of organification. Okay. So two important things you need to know: Jod-Bezos and as well as Wolff-Chaikoff effect. Okay. Then some image based questions. Right? What is this sign and in which endocrine disorder do you observe this? So what do you think is this sign? This particular sign is nothing but Graves' ophthalmopathy. Right? This particular sign is nothing but Graves' ophthalmopathy. Right? So where you have lid retraction is there. You can see that lid retraction is there. Periorbital edema will be there, and even you take the conjunctiva. How is the conjunctiva? Conjunctival redness is there. Conjunctival injection is there. That is called Graves' ophthalmopathy. Then you see the next. What is the dermatological abnormality you are observing over the legs, and in which endocrine disorder do you observe this? Yes. So this will be infiltrative dermopathy. Right? This will be infiltrative dermopathy. Right? So this is nothing but pretibial myxedema. So you will have this in Graves. Right? You will have this in Graves. So that will be the image based question related to your pretibial myxedema. Then next important is, coming to the beta carotenemia. What is beta carotenemia and in which form of thyroid disorder you will have this beta carotenemia? So beta carotenemia is that where there is complete yellowishness of the skin. Right? There will be yellowish skin that will be developed, and all the skin, the entire skin will be yellowish except the eyes. The eyes will be normal in these individuals. And in which endocrine disorder you will have this beta carotenemia? You will have that in case of hypothyroidism. In hypothyroidism, you will have this beta carotenemia. Okay. The next important is why? Because in hypothyroidism, the beta carotene is not converted into vitamin A, and that is the reason why you will have this beta carotenemia, and that will be responsible for your yellowish skin. And how will you differentiate this from jaundice? In jaundice, even the eyes are yellowish in color, but in case of the beta carotenemia, eyes will be normal. Okay. Yeah. Next question. Which endocrine disorder do you observe clubbing of the fingers? Yes. In which endocrine disorder you will have the clubbing of the fingers? And this we call it as thyroid acropathy. So where will you have this? Thyroid acropathy. So where will you have this? You will have this in patients with the hyperthyroidism, where you have clubbing within the finger. Right? Where you have clubbing within the fingers. That is called thyroid acropathy. And whenever you take an X-ray, right, whenever you take the X-ray of this thyroid acropathy, what is that you will observe? You will observe the marked cortical thickening. Right? You will observe the marked cortical thickening. That is what you will observe in thyroid acropathy. Right? Next, then if you see the face of patients with hypothyroidism, so how will be the face of these patients with hypothyroidism? You will have a round and swollen face, and you will have the swollen lips, and you will have loss of hair in the lateral 1/3 of the eyebrow. So that loss of hair in lateral 1/3, that is called madarosis. This madarosis is not just only the feature of hypothyroidism. This madarosis, you will also have that even in patients with the leprosy. Okay? Then, next important is, what are the cardiac manifestations in thyroid disorders? The cardiac manifestations, you should know, what are the cardiac manifestations in hyper, cardiac manifestations in hypo. So, cardiac manifestations in hyper, there will be systolic hypertension, there will be arrhythmias, most common will be atrial fibrillation, there can be development of congestive cardiac failure, there will be a mid-systolic murmur, and the name of that mid-systolic murmur will be means Lerman scratch. Whereas in hypothyroidism, what is that you will have? In hypothyroidism, you will have diastolic hypertension, you will have development of pericardial effusion, right? And there will be also development of first degree AV block, right? First degree AV block. So this will be the cardiac manifestations in patients with the hypothyroidism, right? Then what will be the neurological manifestations in patients with the thyroid disorder? Okay, yeah, tell me this. Hung up reflex. Which thyroid disorder you will have this hung up reflex? Which thyroid disorder you will have this hung up reflex? Anyone? Very good. So you will have this hung up reflex in patients with the hypothyroidism. What is this hung up reflex? Where there will be delayed relaxation, right? Delayed relaxation of deep tendon reflexes. That is called the hung up reflex. And this is one of the reliable sign for your hypothyroidism. Then next important sign you need to know is the Pemberton sign, right? Where do you get this Pemberton sign? You will get this Pemberton sign with retrosternal goiter. What is this? On raising the arms of the individual, there will be facial congestion. And how will you diagnose this retrosternal goiter? That is by CT or the MRI. Next is metabolic disorders. Yeah. Which of the following disorder can cause profound hyperlipidemia? Which of the following can cause profound hyperlipidemia? So, the condition which will cause profound hyperlipidemia, not hyperthyroidism, it is your hypothyroidism. That will cause profound hyperlipidemia, and because of which there will be accelerated atherosclerosis. And that can cause coronary artery disease. That is what you can see in case of patients with the hypothyroidism, right? Then we have two important extreme forms of thyroid disorders, that is thyroid storm and myxedema coma. You should know how to treat this thyroid storm. You should give the intravenous beta blockers. You should give nasogastric propylthiouracil. What this propylthiouracil will do? Propylthiouracil will inhibit conversion of T4 to T3. And you should also give Lugol's iodine. Lugol's iodine, it will inhibit the release of thyroid hormone. So these are the drugs that you should give in case of thyroid storm, which is extreme form of hyperthyroidism. Then what is extreme form of hypothyroidism? The extreme form of hypothyroidism will be myxedema coma. So myxedema coma, it is an extreme form of hypothyroidism, right? How do you treat these patients? You have to give intravenous T3 or intravenous T4. Usually what we give oral formulations, but in case of myxedema coma, you should give intravenous T3 or intravenous T4, and you should also give hydrocortisone because the adrenal reserve will be reduced in these patients. So you should give the intravenous hydrocortisone should be given. Okay, that will be your myxedema coma. Then how do you investigate these patients? We use the radioactive iodine uptake study. So if you take this radioactive iodine uptake studies, which radioactive iodine we use? That is iodine 123 or iodine 132 we use. But for treatment, which is the radioactive iodine we use? That is iodine 131 for therapeutic purpose. For diagnostic purpose, it is iodine 123 or iodine 132. And you should know all the conditions where there is high radioactive iodine uptake, like your Graves, toxic nodule, autonomous nodular goiter. And what are the conditions where you have low radioactive iodine uptake? That is subacute thyroiditis, lymphocytic thyroiditis, postpartum, all that you have low radioactive iodine uptake. Then you should know how to treat patients with hyperthyroidism and how to treat patients with the hypothyroidism. Yeah, a pregnant woman diagnosed to be suffering from the Graves disease. So what do you think is the most appropriate therapy for her would be? Yes, what would be the most appropriate therapy for her would be? Any one of you? Right, that will be the propyl thiouracil. So actually in case of hyperthyroidism, what is the drug of choice? Drug of choice will be methimazole. Right, drug of choice will be methimazole. But if you take in pregnancy, right, but if you take in pregnancy, what is the drug you will give in first trimester? What is the drug you will give in second trimester? And what is the drug you will give in third trimester? In first trimester, we give propyl thiouracil. But in second and third trimester, we give methimazole. Why is that we don't give methimazole in the first trimester? Because methimazole is teratogenic. It will cause aplasia cutis. That is the reason why we don't give methimazole in the first trimester. Right? Whereas in second and third trimester, organogenesis is over. That is the reason why we give methimazole. Okay. Then, next question. A 40-year-old female who is known case of ischemic heart disease, it is diagnosed of having hypothyroidism. Which of the following would be the most appropriate line of management for her? Yes, any one of you? The individual is having ischemic heart disease. So, you should not start a full dose thyroxine. You have to start low dose thyroxine. Okay. So, if you take the treatment of your hypothyroidism, what we will give? We will give levothyroxine, which is nothing but T4. We have to give orally, right? When will we give? We give early morning, and that too in a fasting state, right? That too in a fasting state. And what is the dosage of levothyroxine? The dosage will be 1.6 micrograms per kg you should give, right? And you should decide what should be the dose. You should decide what should be the dose. So if there is any cardiac disease, right, if there is any cardiac disease present, then you have to give low dose. If there is no cardiac disease, then you can give full dose of levothyroxine. Then you should give full dose of levothyroxine. Okay, so that is about the treatment of hypothyroidism. So this finishes the topic of your thyroid disorders. Done. The next important topic is diabetes mellitus. Right, next important topic is diabetes mellitus. So now you see this question: which of the following endocrine disorder does not lead to diabetes mellitus? Which of the following disorder does not lead to diabetes mellitus? Pheochromocytoma, somatostatinoma, hypothyroidism, acromegaly. Very good. So hypothyroidism, right? Hypothyroidism, you will not have the development of diabetes mellitus. The remaining all, pheochromocytoma, somatostatinoma, acromegaly, there is development of the diabetes mellitus. And regarding the diabetes mellitus, what are the other endocrine disorders that can cause diabetes mellitus? The other endocrine disorders that can cause diabetes mellitus is glucagonoma. Then, apart from these three which has been mentioned here, hyperthyroidism, right? So these are the conditions which will cause diabetes mellitus, right? Now, after having said this, some image-based questions we'll discuss related to diabetes mellitus. What is this instrument? What is the use of this particular instrument? Any one of you? Yeah, yes, Irfan, very good. Even Cushing's also will cause diabetes mellitus. Right. So this particular instrument, it is a monofilament test. Right. It is a monofilament test. Okay. And what is the name of this monofilament test? It is a two-site semi-Swinstein monofilament test. And what is the purpose of this? That is mainly to test for peripheral neuropathy. That is mainly to test for peripheral neuropathy. Okay. So this is semi-Swinstein monofilament test. Okay. Next. Now this question has been repeated almost 3 or 4 times in FMG exam. Right. In the recent FMG exam also this particular question was there. Okay. Yeah. What is this sign and in which clinical condition do you see this? Very good. So this is nothing but your prayer sign. Right. This is nothing but prayer sign. And what is this called? This is also called diabetic chiropathy. What is the problem? The problem will be the individual will have a limited joint mobility. Right. Where the individual will have a limited joint mobility. So this is how it will be, limited joint mobility. And when the sugars are corrected, right, when the sugars are corrected, then the individual will be able to approximate both the hands. That is what is called prayer sign, which is called diabetic chiropathy, or which is we also call this as diabetic stiff syndrome. We also call this as diabetic stiff syndrome. Next important is, yeah, which endocrine disorder, okay, in which endocrine disorder do you see this? What is this? And in which endocrine disorder do you see this? So first of all, what is this? It is xanthelasma, right? And which endocrine disorders you can have this? This xanthelasma, it is nothing but yellowish cholesterol rich material, and you can come across this in case of diabetes mellitus. In diabetes mellitus, you will have this development of xanthelasma. Next important is, right, in which endocrine disorder do you observe this particular complication? So first of all, what is this complication? This complication, it is a neuropathic foot ulcer. Right, it is a neuropathic foot ulcer. You will have this in case of diabetes mellitus. So how can you tell that it is a neuropathic foot ulcer? Because the edges are clean. Because the edges are clean. And margins, the margins, they are regular margins. And where are they present? They are located on the plantar surface of the foot. Whereas in ischemic ulcers, they don't develop over the plantar aspect. The ischemic ulcers, they are located at the toes. And ischemic ulcers, they have irregular margins. But here the margins are regular margins. It is like typically punched out appearance, right? And the lesions are present on the plantar surface of the foot. Okay, that will be neuropathic ulcer. Next, we have one more dermatological manifestation. Yeah. What is the name of this dermatological sign and in which endocrine disorder do you observe this? Yes. Right. So, this is necrobiosis lipoidica diabeticorum. Right. Okay. So, one of my brother, Shamim Akhtar, see, having anxiety is a normal thing at this point of time. If you don't have anxiety, that is abnormal. Okay. So, please don't worry about the question paper. Question paper will definitely be an easy paper because you won't believe what sort of questions have been asked in your recent INICT exam, right? They didn't ask what type of acid base abnormality is your high anion gap, right? You know, the simplest questions have been asked in the recent INICT exam. The same will be even for your FMG exam also. Just be calm and quiet. Definitely you will clear the exam. And if you are in class 10th, शमीम, यू आर इन क्लास 10th। बहुत टाइम है आपको इधर आने के लिए। ओके। Right. So, what is this dermatological lesion? This dermatological lesion will be necrobiosis lipoidica diabeticorum. So, this necrobiosis lipoidica diabeticorum, where do you come across this? You will see that in patients with the diabetes mellitus. And usually it is seen over the lower legs, that is in the lower limbs, and it is more common in women. And how will be the lesions? They are like shiny red, brown, yellowish patches. Okay, so that will be your necrobiosis lipoidica diabeticorum. And one more dermatological complication that you will come across in diabetes mellitus will be acanthosis nigricans, right, where you have dark velvety skin, right, where you have dark velvety skin. Okay, right. So right. Next is, you should know this type 2 diabetes mellitus will correlate with which fat reserve? Type 2 diabetes mellitus will correlate with which fat reserve? So, it will correlate with the abdominal fat. Central obesity. Central obesity is the most common risk factor for the development of type 2 diabetes mellitus. Why? It can cause the insulin resistance. So what are all the risk factors for type 2 diabetes mellitus? The risk factors for type 2 diabetes mellitus will be: number 1, central obesity; number 2, vitamin D deficiency; number 3, smoking, right, number 3, smoking. And next, the next important risk factor for your type 2 diabetes mellitus will be inadequate physical activity, right, inadequate physical activity. So these are all the risk factors for your type 2 diabetes mellitus. Now I'll just show you one clinical scenario. Please answer this. So a 29-year-old male taking oral hypoglycemic drugs, never had ketonuria in his life. BMI is 20.5. Grandfather has diabetes. Father is also diabetic. Right? Which type of diabetes is this person most likely suffering from? Very good. So this is a classical case of MODY. So what is this MODY stands for? MODY, it stands for maturity onset diabetes of young. So in maturity onset diabetes of young, it is mainly due to beta cell dysfunction. Right? It is mainly due to beta cell dysfunction. They have very strong family history. Right? They have very strong family history. Right? And minimum 2 generations will be diabetic. And BMI will be absolutely normal in these patients. They will never develop diabetic ketoacidosis. And it is mainly due to gene mutation. And what is the most common gene that is being mutated? That will be HNF1 alpha. And HNF1 alpha, you come across this in MODY 3, maturity onset diabetes of young, type 3. And what will be the drug of choice? That will be low dose sulfonylurea. Right? Low dose sulfonylurea. Okay. So these are the features of your maturity onset diabetes of young. And we have one more important form of diabetes, that is type 1.5 diabetes mellitus, which is also called LADA. That is latent autoimmune diabetes of adults. So this is seen in adults and it is autoimmune. So autoimmune in the sense the antibodies are formed. And what are the antibodies? These antibodies are anti-GAD antibodies. And these antibodies, they destroy the beta cells. So what will be the drug of choice? drug of choice will be insulin. Right? Drug of choice will be insulin. So that is what is your type 1.5 diabetes. Okay. Then how will you diagnose these patients with the diabetes mellitus? By fasting, postprandial and HbA1c. How much is the normal fasting levels? Less than or equal to 100. When will you call impaired? 101 to 125. When will you call diabetes mellitus? More than or equal to 126. And how much will be ppbs? Normal value will be less than or equal to 140 and impaired 141 to 199. Diabetes more than or equal to 200. HbA1c normal value will be less than or equal to 5.6. Impaired value will be 5.7 to 6.4. Diabetic range will be more than or equal to 6.5. Okay, so that is about your how you will diagnose diabetes mellitus. And HbA1c is very important investigation, right? It is a retrospective test. Okay, and the value of your HbA1c, it doesn't get affected by your exercise or food, right? And what is the importance of HbA1c is it is directly proportional to microvascular complication. More is your HbA1c, more is the chance of development of the microvascular complication, right? More is the chance of development of microvascular complication. So HbA1c multiplied by 25 will give you average blood glucose levels, right? Will give you average blood glucose levels. And how much should be the target HbA1c? The target HbA1c in a diabetic patient, that will be less than 7. Then yes, what is the gold standard investigation? Gold standard investigation will be OGTT, oral glucose tolerance test. That will be the gold standard investigation. Okay, then you see the next question. Early morning hyperglycemia with increased blood glucose of 3 a.m. suggest. Early morning hyperglycemia with increased blood glucose of 3 a.m. suggest. So this will suggest what? Okay, so this is one important area where the questions will be asked. Don's phenomenon, Somogi, all that we will discuss now. So what are the causes of, we will discuss and go back to that question again. What are the causes of early morning hyperglycemia? One is fasting hyperglycemia, that is due to inadequate insulin, right? That is due to inadequate insulin. Okay, so how will you diagnose? Because the individual has taken inadequate insulin, both 3 a.m. and 6 a.m. insulin, 6 a.m. and your 3 a.m. blood glucose levels will be high. Okay, Don's phenomenon. Don's phenomenon is due to what? Don's phenomenon is due to early morning physiological surge of the growth hormone. Okay, early morning physiological surge of the growth hormone. What the growth hormone will do? Will increase the blood glucose levels. So 3 a.m. blood glucose levels will be normal, 6 a.m. blood glucose will be high. Why? Because early morning growth hormone surge. Okay, then Somogi effect. Somogi effect is due to excessive night dose of insulin. Right? Excessive night dose of insulin. So when the individual is taking excessive night dose, what will happen to his 3 a.m. blood glucose levels? Reduces. When 3 a.m. blood glucose level reduces, there will be activation of counter-regulatory hormones in the morning, and thereby 6 a.m. blood glucose levels will be high. So this hypoglycemia at 3 a.m. will induce hyperglycemia by increasing the levels of counter-regulatory hormones. What are counter-regulatory hormones? Glucagon, growth hormone, steroids, thyroid hormone, catecholamines. These are all counter-regulatory hormones. So once there is increase in your counter-regulatory hormones, 6 a.m. blood glucose levels will be high. So that is what is your Somogi effect. So what do you think is the answer in this question now? Early morning hyperglycemia with increased blood glucose of 3 a.m. suggest. So that means Early morning 6 a.m. also blood glucose levels are high. 3 a.m. also the blood glucose levels are high. So where can you have this? You can have this in case of insufficient insulin, right? Insufficient insulin. This is not Dawn's phenomenon. This is not Dawn's phenomenon. It is insufficient. Dawn's phenomenon में क्या है हरजीत? 3 a.m. blood glucose levels will be normal. 6 a.m. blood glucose levels will be high in Dawn's. What is been asked? Early morning hyperglycemia. Increased 3 a.m. blood glucose levels. So this is what is suggestive of your insufficient insulin. Okay, it is not your Dawn's, it is not your Somogi. Then next is, yeah, a type 2 diabetes mellitus patient present with fasting blood glucose 180, postprandial 260. What does the management include? What does the management include? So what is these levels? These levels, they are in diabetic range. So the treatment will be, actually what is the first line treatment in diabetes mellitus? First line treatment in diabetes mellitus will be lifestyle modification, right? And the next important drugs, in the drugs, what will be the drug of choice in type 2 diabetes mellitus? Drug of choice will be metformin, right? So why metformin is considered as drug of choice? Metformin is considered as drug of choice because it will cause maximum reduction in your HbA1c, right? And maximum reduction of HbA1c. That is the reason why metformin is considered as drug of choice. And metformin, what are the other advantages? It will cause weight loss. Metformin will cause weight loss. Metformin will never cause hypoglycemia. That is the advantage of your metformin. Okay. Then coming to the complications. Yeah. What is the most useful investigation in the diagnosis of diabetic ketoacidosis? Most useful investigation in the diagnosis of diabetic ketoacidosis. Very good. So it will not be your urine ketone bodies. It will be ketonemia. Why? Because some ketone bodies like beta hydroxybutyrate, this beta hydroxybutyrate does not appear in the urine, right? Does not appear in the urine. So that is the reason why urine ketone bodies are not the most useful investigations. Okay. So if you take the complications of diabetes mellitus, how do we classify the complications? We classify the complications into acute and as well as chronic. So what are the acute complications? The acute complications that the individual can develop is diabetic ketoacidosis and hyperosmolar non-ketotic coma, right? And what are the chronic complications? The chronic complications, we classify that into microvascular complications and then macrovascular complications. So in 2021 June exam, they have just asked what are the microvascular complications. So that will be diabetic neuropathy, diabetic nephropathy, and the diabetic retinopathy. Then what are the macrovascular complications? That will be your coronary artery disease, cerebrovascular accidents, then peripheral arterial disease. That will be macrovascular complications. So these are basically your chronic complications. And you also have avascular complications. What are avascular complications? That will be skin manifestations. Just now we have discussed necrobiosis lipoidica diabeticorum and acanthosis nigricans. And one more avascular complication will be diabetic amyotrophy, right? Where there will be proximal muscle weakness. Where there will be proximal muscle weakness. And these individuals, they can also have development of glaucoma and there will be also development of cataract. Okay. Some quick points about diabetic ketoacidosis. Quick points about diabetic ketoacidosis. What is a triad? The blood glucose levels will be more than 250. The pH will be acidic pH. That means pH will be less than 7.36. And the ketone bodies will be positive. Right? What are the ketone bodies? Acetone, acetoacetate, and beta hydroxybutyrate. And what type of metabolic acidosis? It is high anion gap metabolic acidosis. Respiratory pattern is very, very important. That is Kussmaul's respiration, which is a periodic breathing where there will be increase in the depth and also increase in the rate of respiration. What will be the first line treatment in diabetic ketoacidosis? That will be normal saline, Followed by that, we give insulin. And which type of insulin? We give regular insulin. And what will be the route of administration of insulin in diabetic ketoacidosis? That is the intravenous route. That will be the intravenous route. Okay. Next, one more important acute and your diabetic ketoacidosis, it is more common in type 1 diabetes mellitus rather than type 2 diabetes mellitus. That is about your DKA. Then next what we have is HONC, hyperosmolar non-ketotic coma. Hyperosmolar non-ketotic coma, it is more common in type 2 diabetes mellitus rather than type 1 diabetes mellitus, right? So it is the most common acute complication in type 2 diabetes mellitus. What about the ketone bodies? The ketone bodies will be absent. But how much will be the blood glucose levels? The blood glucose levels will be more than 600 to 1200 milligrams per deciliter. And that is the reason why your osmolarity is increased. And what will be the first line treatment? That is again IV fluids. And which particular IV fluids we give? That will be half normal saline. And followed by that, we give insulin. And what is the type of insulin we give? That is regular insulin. That is what we give. Right? That is the regular insulin. That is what we give. Okay. Next, coming to the microvascular complications. Okay. So in the microvascular complications, what is the sensation lost first? The sensation lost first will be the sensory sensations. And within the sensory sensation, which particular sensory sensation is lost first? The sensory sensation that is being lost first will be vibration sense, which is being lost first. Then what is the most common type of neuropathy? It is distal symmetrical sensory neuropathy. That is the most common type of neuropathy that you will see in diabetes mellitus. And most common cranial nerve that is being affected is third cranial nerve. Followed by that, there will be involvement of the seventh cranial nerve. And in these individuals, there will be also development of diabetic autonomic neuropathy, due to which there will be postural hypotension. And what is the drug of choice for autonomic neuropathy causing postural hypotension? That will be midodrine. Right? What is midodrine? It is an alpha agonist. Usually it is given in the treatment of hypotension. Okay. Next. So that was about the diabetic complications. You see this question. A patient present with symptoms of hypoglycemia. Investigation revealed decreased blood glucose and increased insulin levels. C-peptide is done, which shows the normal levels of C-peptide. So what do you think is the most likely diagnosis in this case? What do you think is the most likely diagnosis in this? So hypoglycemia is there. Investigation revealed decreased blood glucose, increased insulin, C-peptide levels are normal. Right. That will be accidental exogenous insulin administration. Now why? That is because the insulin levels are high, but the C-peptide levels are normal. But the C-peptide levels are normal. In case of exogenous insulin administration, you don't have C-peptide. But whereas in these two conditions, the insulin levels will be high and even C-peptide levels are also high. Because the insulin which is coming from the beta cells, the C-peptide levels are elevated. C-peptide levels are elevated for the insulin which is coming from your insulinoma or accidental sulfonylurea ingestion. And what about metformin? Metformin will never cause hypoglycemia. Will never cause hypoglycemia. So that was about your diabetes mellitus. Now, coming to the MEN syndromes. That is multiple endocrine neoplasia syndrome. So MEN syndrome, you take MEN1. Okay, MEN1, it is also called as Wermer syndrome. What is the tumors of MEN1? Three important P's. Okay, pituitary tumor, parathyroid tumor, and pancreatic tumor. But which is the most common? The most common will be parathyroid tumor. Which is the second most common? That will be pancreatic tumor. And which is the third most common? That will be pituitary tumor. That is prolactinoma. Coming to MEN2A, that is also called Sippel syndrome. So that will be parathyroid tumors will be there, adrenal pheochromocytoma will be there, and medullary carcinoma of thyroid will be there. That is called MEN2A, which is also called Sippel syndrome. Whereas in men to be, you don't have parathyroid tumors. Parathyroid tumors will not be there. Only pheochromocytoma will be there and medullary carcinoma of thyroid will be there. And in all these, you also have extra endocrine manifestations. What are those? In case of men 1, you have foregut carcinoid. Right, you have foregut carcinoid, and not only that, you also have visceral angiofibromas and collagenomas. Whereas in men 2A, which is also called Sippel syndrome, the extra endocrine manifestations will be Hirschsprungs, and there will be also development of amyloidosis. Right? Whereas men 2B, which is also called men 3, the extra endocrine manifestations will be neuromas, and the individual will also develop marfanoid habitus. Right? And in men 1, what is the gene mutated? Men 1 gene. And men 1 gene, on which chromosome it is present? It is present on chromosome 11. Whereas in men 2A and men 2B, the gene which is being mutated is RET proto-oncogene, and it is present on the chromosome 10. It is present on chromosome 10. Then you take men 4. Men 4, you have reproductive organ tumors. Right? You have reproductive organ tumors. And what will be that reproductive organ tumors? There will be cervical tumors in females, right? And there will be testicular tumors in males. Okay. And men 4, what is the gene which is being mutated? The gene which is being mutated is CDKN1B. That is the gene which is being mutated in men 4. Okay. Then next important question is, yeah, Werner syndrome. It is associated with what? Right? Werner syndrome is associated with what? So Werner syndrome is not your men 1. The answer is none. So what has been asked for you is Werner's. What is men 1? Men 1 is Wermer's. Right? Men 1 is Wermer's. Okay. What is Werner's then? Werner's is your progeria. Right? Werner's is your progeria, which is nothing but premature aging. Right? Werner's is nothing but progeria, which is nothing but premature aging. So that is about your Werner's. Okay, right. So we are done with the men syndromes, multiple endocrine neoplasia syndromes, and two more conditions I'll discuss. That is carcinoid, and the other one is glucagonoma. Right. Coming to the carcinoid. So what are these carcinoid? It's a slow growing type of neuroendocrine tumors. It's a slow growing type of neuroendocrine tumors. Okay. And what does this carcinoids produce? Mainly the serotonin. Okay. So this carcinoid syndrome, if you see, you have two types: typical carcinoid and as well as the atypical carcinoid. Typical carcinoid is what? Where there will be increase in your plasma serotonin and there will be elevated 5-hydroxyindoletic acid. What is atypical carcinoid? In atypical carcinoid, plasma serotonin levels will be normal, but what is elevated? It is 5-hydroxytryptophan that will be increased. That is called your atypical carcinoid. And in case of typical carcinoid, where there will be increase in your plasma serotonin levels, the argentafin will be positive. Whereas an atypical carcinoid, it is argentafin negative because your serotonin levels are normal. Because your serotonin levels are normal. Okay, that is what is the difference between typical and atypical. So in typical, serotonin levels are elevated, whereas in atypical, 5-hydroxytryptophan levels are elevated and it is argentafin negative. So we have a terminology called carcinoid heart. What is carcinoid heart? Carcinoid heart is that where the right-sided valves are commonly affected. Right? And that too, which side of which particular valves on the right side? Tricuspid valve is most commonly affected. And please remember the mnemonic TIPS. What is TIPS? That is tricuspid insufficiency, Tricuspid insufficiency is nothing but tricuspid regurgitation. PS stands for pulmonary stenosis. That is what is your carcinoid heart. Then not only the heart which is affected in case of your carcinoid, even there is also gastrointestinal manifestation in the carcinoid that will be in the form of diarrhea. And even respiratory manifestations will be there in carcinoid, and this respiratory manifestations will be there in the form of wheeze. That is what in the carcinoid. And how will you diagnose this carcinoid? The diagnosis, the typical carcinoid, 5-hydroxy indolactic acid levels are elevated. In atypical carcinoid, 5-hydroxy tryptophan levels are elevated. Then how will you localize the tumor? Localization of the tumor is by the octreoscan. So octreoscan is the one which helps in localizing this carcinoid tumor. But the octreoscan, the sensitivity is slightly less. So the improved sensitivity, that will be your gallium 68 dotatate scan. Gallium 68 dotatate scan, it is very much superior to the octreoscan in localizing the tumor. Then how do you treat these patients? So for symptomatic relief of the carcinoid syndrome, what will be the drug of choice? Drug of choice will be octreotide. Right? Drug of choice will be octreotide. So what this octreotide will do? Octreotide will decrease the breakdown product of the serotonin. Right? It will decrease the secretion of serotonin. It will decrease the breakdown product of serotonin. That is what is the treatment for your carcinoid syndrome. And the last important topic in the endocrinology will be glucagonoma. Glucagonoma has been asked recently. In the recent FMG exam, this question about the glucagonoma has been asked. So glucagonoma as such, it is a very rare tumor. And where is it originating from? It originates from the alpha cells of the pancreas. What these alpha cells will do? It will produce the glucagon. Glucagon, what it will do? It will increase the blood glucose levels. So the individual will develop mild diabetes mellitus. It's a tumor. So that is the reason why there will be weight loss in the individual. And you have a typically associated rash. And the typically associated rash is necrolytic migratory erythema. Right? Necrolytic migratory erythema. And these glucagonomas are associated with MEN1. Right? Are associated with MEN1. So how will you diagnose this glucagonoma? You have to do blood glucagon levels. When you do a blood glucagon levels, the blood glucagon levels will be more than 500 milligrams per deciliter. That is how you can diagnose the glucagonoma. Right? And what will be the drug of choice? The drug of choice will be your somatostatin analog, that is octreotide. So what this octreotide will do? This particular octreotide, it will inhibit the release of glucagon. Right? Will inhibit the release of glucagon. Now for suppose, if you want to selectively destroy the alpha cells, selective damage of the alpha cells can be done by two important drugs, that is doxorubicin and as well as streptozotocin. So this doxorubicin and streptozotocin, they selectively damage the alpha cells. Okay, so that is about your glucagonoma. So glucagonoma, where there will be mild diabetes mellitus, weight loss, and necrolytic migratory erythema associated with MEN1, diagnosed based on the glucagon levels. Drug of choice will be octreotide, and if you want to selectively damage the alpha cells, you can give doxorubicin and as well as the streptozotocin. Okay, so this finishes your endocrinology. Right? So just before the break, we have finished cardiology. Now we have finished endocrinology. Almost each chapter, if you want me to discuss in detail, it is taking almost 2 hours. Okay, so what I will do here, right? So we are done with this two important chapters. We are done with these two important chapters. So like any doubts until here, you can just text me on my Instagram handle, as I have said you previously also, that is Rajesh Gubba. You can follow me on my Instagram handle, where you will have some quick pointers which will be useful for your upcoming FMG and NEET PG exam. And this particular session I will stop now. and I will continue the session tomorrow. Right? I will continue the session tomorrow. So tomorrow, same timing at 2:30 p.m. we will continue with the remaining topics in the general medicine. Okay. So until here, so if you have any doubts, you can just text me on my Instagram handle, that is Rajesh Gubba. Right? And this material I will attach, this PDF I will attach to my Instagram handle. So you can just come on to my Instagram handle, and you can get this particular PDF on my Instagram handle. Okay, right? Thank you very much. See you tomorrow again at 2:30 p.m.